All right. Let's see. We're trying to go live right now. Excellent. We are live. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, November 23rd of 2025, and it is time for another live IC support group meeting. I know I had some phone calls wondering where I was last week. As I had shared in our previous meeting, we had a very important family event, and so that's why I was not here last Sunday, but I am here this Sunday for you. I am here to take questions. I am here to give you support. I am here to educate, to inform, to comfort, anything that I can do to help you in your struggle and journey with pelvic pain. That is what I want to do. Now, we're live streaming right now. We're live streaming on YouTube and Facebook. So we're going to have, when I'm kind of looking over this way, I'm looking at YouTube. When I'm looking over this way, I am looking at Facebook. Now, for those of you who have already come in, if you could just say in the chat, make sure the sound is okay. I'd really appreciate it because we certainly have a long history of sound issues trying to stream on both platforms. All right. So let's just give it a couple minutes for more people to come in. In the meantime, how you doing? How's life? Hello, Anne. Anne says, can I take amitriptyline as needed? Why do I get burning started in the afternoon when morning is okay? Julie says, the sound is good on Facebook. Yes. I'm so glad. No, honey, amitriptyline is not a pain medicine per se. You don't take amitriptyline when you're flaring. Generally, the way amitriptyline works is you use low doses over time, and what that does is that acts to slowly and steadily calm your nerves down. We have had patients overdose thinking that they could do that, thinking that they could take more and more amitriptyline when they have flares. It just does not work that way. Amitriptyline does not behave like a typical pain medicine. Hey, Christy, thank you. Yep, you guys, the hair is gone. I'm tempted to take more. I was done, my friends. I was done. We took 15 inches off. It was time to shed the stress and trauma of the past couple of years and start fresh. So thank you. I really, really appreciate it. It has been a journey. Now, I'm not quite sure what's going on with YouTube here. So we'll just see what happens with YouTube. You never know. Thank you, Lori. There's a very funny story behind this. I had to actually get it cut twice because the lady who normally does it does not do long hair anymore. And so I found somebody who did an absolutely terrible job. And so literally 2 days later, I had to go to somebody else to fix it. So, and I don't like getting my hair cut. I'm weird about that. So anyway, okay. So this is what we have on the agenda today. We're going to talk about Lyme disease and how Lyme disease can affect the bladder. We're going to talk about Thanksgiving because Thanksgiving is just 4 days away. And our challenge here is that, there are multiple challenges with Thanksgiving, from food to traveling to expectations to explaining IC to family and friends. Thanksgiving, holidays in general like this can be challenging, especially if you're newly diagnosed IC patients. But we're going to start with this, my friends. It's done. The new, updated, revised, expanded flare guide is now done. My original intention was to do this last year, but hello, I had breast cancer. And then after my surgery, I couldn't sit at my computer for about 6 months without crying because the incisions hurt so badly. So it's taken me a year longer to do it, but I am very happy to announce that our flare guide is now officially done. It's not, and this is a fundraiser for the IC network. This is designed to keep us going, right? Because we got to keep going because there's a lot of people out there who need us. It is $9.95 as a PDF file, 80 pages of the best wisdom we've gained in the last 30 years with IC. If you want it in print, it's, I think, $16.95. And the reason why it's so expensive in print, and granted, that's not that expensive, is that the cost of paper is doubled. Like literally, it's $10 just to print it. So it's not like we're making a lot of money off this. The goal here is to give you a resource that will get you through those nights when you're flaring so badly. Our goal here is to help you understand that there are different types of flares. What makes this different than any other guide out there is I talk very, very specifically about how your phenotype determines the types of flares you're going to have. Because here's a fundamental problem. Pretty much every flare feels like an infection. I mean, listen, we've all been there. I've been there. And so it is your own natural instinct to go into your bedside table, grab some old antibiotics that you've saved and go, okay, well, maybe this is just an infection. And it doesn't work. I mean, for the vast majority of time, that doesn't work. And the other great confusion is that it's just so confusing what causes flares. Because for some people, flares are from food. For other people, flares are from sex and from driving. My worst flares happened after driving by far. And so if you're having a driving flare or a sex flare, which is a pelvic floor-driven flare, you can do all the bladder therapies you want. It's not going to fix it. Because our job here is to try to get these muscles out of tension. That flare you have when you're driving, that flare you're having after sex, means that muscles are tight. In many cases, muscle spasm. I can tell you right now, if I got to get on a bus and go to San Francisco International Airport, I will go into pelvic floor spasms by the time I get there. It's been that way for 30 years. It's one of the reasons why I don't like traveling very much. And it's one of the reasons why I always travel with a muscle relaxant. So in this book, we talk about bladder wall flares, pelvic floor flares. And in the pelvic floor section, I mean, this is the first time where we really go into, we give you very strong specifics on what you can do to try to get these muscles out of tension and out of spasm. Every section has triggers, rescue plans, triggers and rescue plans. This is the first time we're talking ever about a pudendal neuralgia flare. That's that flare that happens when your muscles get so tight, they squeeze nerves. So you might have sciatica, you might have pins and needles, you might have areas of numbness. Do you know that some people, this is so interesting, some people who flare, their feet go numb. Their feet go numb, one foot or both feet. I've worked with them. You know what that is? That means that their muscles have gotten so tight, they're squeezing a nerve. So when we're having a pudendal neuralgia flare, we got to accomplish two things. We got to relax the muscle and we have to calm the nerves down. And we talk very specifically on how you can do that. Let's see. And one of the most important things you've got to really understand about when you have pain when you sit down that gets better when you stand up, what you sit on matters. What you sit on matters. If you're sitting on something hard, that's going to be a problem. You got to really pay close attention to what you're sitting on, and it has to be fairly soft so you're not hurting that nerve. We talk about stress flares. Now, seriously, we've all had a stress flare. Some of you are going to have stress flares before Thanksgiving. You are, because holidays are stressful. Holidays bring out all sorts of challenges for many patients for a number of reasons. So we talk about how to get yourself out of that stress flare. And guess what? It's not bladder treatment. It's not bladder treatments. Talk about the urethral flare. What do you do when your urethra starts screaming in pain? I've got somebody right now that I'll be doing some coaching with either later today or tomorrow who's suffering from horrific urethral pain right now. So what can we do to calm that little tiny tube that's such a problem? All right. I do not know what's happening here on YouTube. Hold on a sec. Let me look at something here real quick. Well, I mean, on my end, it looks like it's working, but I can't tell. Okay. We talk about vulvodynia flares. What do you do when your vulva is screaming? And for those of you who just came into YouTube, could you do me a favor and put a message down there and tell me if it's working or not? Do you have sound? Because I'm getting mixed messages from YouTube. We talk about rectal flares. What do you do when your rectum is screaming at you? Look, you got a hot little burr up there. We talk about sex flares, the fact that men and women with IC and pelvic pain experience their flares very, very differently. Allergy flares. And then we have a lot more articles in here. Things like how do you differentiate between a UTI and a flare, or what can you do if you flare while you're driving? All right. And, you know, a little bit controversial, but a whole little article here on smoking and vaping. Smoking and vaping can be a challenge. So anyway, the IC 101 Flare Guide is now available in the IC Network store. You can, if you just go over to icnetwork.org, click on store, you'll see it on the front page of our store. And I just, you know, I had a rough couple of years, and when you're naked and crying and you've got people helping you to the bathroom and all this other stuff and looking at your incisions, it is very humbling, and your priorities change massively. And to suffer is horrific. And I suffered from my IC 30 years ago, and I suffered a year ago from everything that I went through for breast cancer. And I wanted to do something that would ease your suffering. Gunvar, when can I send it to Europe? If you email me, icnetwork@mac.com, I can let you know. Okay. I should be able to send it to Europe. But I'm probably going to do it a different way. Okay. So anyway, now available in the IC Network shop. If you like what we do, if you're struggling with flares, please come on over and check it out and buy it, because it will keep us going. You know, I couldn't work for about 6 months last year, and that was the first time we really hit financial challenges with the IC Network. So now I'm building back up. I will also tell you that the diet guide is now virtually done. Our reviewer, Bev Lauman, sent it back to me. I've got a couple of little changes. So the diet guide should be out after Thanksgiving. So happy, because we needed another new diet resource. So you're going to really love that. I'm not going to show you that yet. I'll show it to you next week. And then we've got the pain guide, which I haven't started writing yet, our medical records file, which is more than halfway done. So that'll be the next one. Then we'll be doing the pain guide. And then I've got something else I'm working on too, on ketamine cystitis. So busy here at the IC Network. As always, for anybody out there who is flaring, if you're struggling, if you just don't know what to do next, you are welcome to call our office at any time. We are the National IC Support Group. The vast majority of IC Network of IC support groups, in fact, all of them died during COVID, but ours, any live groups and live people and live support. So, you know, I'm here and I'm kicking. Hello, Kylie. How are you, hon? Nice to see you. All right, let's go back here to Facebook here for a moment. Hi, Christy, if I didn't say hi to you before. Hi, Lori, thank you. Yeah, it's such a relief. Anne says, why do I get burning in the afternoon? It's been happening a lot lately. Anne, you got to tell us where the burning is, honey. Where is it? Is it on the outside on your skin, or is it on the inside? If it's on the inside, where is it on the inside? Is it in your urethra? Is it in your bladder? Is it on your vulva? Is it in your vagina? That's what we want to know. Lori says she wants this book. Thank you. I really think it's going to help. Joanne, thank you so much for your kind words. Gunfar is from Denmark. Yes, Gunfar, I am 100% Scandinavian. I always look out for my Scandinavian friends. No doubt about that. Johanna says, I'm having a flare-up. I had a passion fruit cocktail last night, and I'm dying right now. Yee. So you had a cocktail. So there are two things we're going to look for in this flare. First of all, alcohol. What alcohol did you use? And if you've got a vulnerable bladder wall and you pour alcohol in it, your bladder's going to sting. You guys, now I don't know. Now for you young folks, you might not remember, you might not know about what we older folks went through in the 60s and 70s and 80s, because when we had a cut, man, they poured alcohol on it. And, you know, mom would be stretching your arm out and you'd be going, no, it hurts. And that's exactly the way our bumps and bruises were treated. Alcohol on a wound hurts. Alcohol on a wounded bladder absolutely is going to hurt. The other question, though, with cocktails is I would really love to know if they used a fruit juice in it. I mean, passion fruit, off the top of my head, I'm not sure about passion fruit. I mean, most of the tropical fruits are good for ice, you know, for most of us who are bladder sensitive, as long as it's really ripe. So if they put pineapple juice in it, if they put orange juice in it, if they put lemonade in it, you got the double whammy of the lemon and the alcohol. That's probably why you're screaming right now. So what are we going to do for this flare? Number one, you're going to dilute your urine. Make sure you're drinking water. We got to flush it out. Number two, you can alkalinize your urine with some Tums, some pre-leaf, even a tiny bit of baking soda and a glass of water. We're trying to reduce some of the acid-induced irritation there. You could potentially use an azobladder pain caplet, which is the over-the-counter version of pyridium. That's the stuff that turns your urine orange. That's going to numb your bladder wall. It works for mild flares, but not for severe flares. It never worked for me. And this is where an aloe product might be helpful. A little bit of Allopath. We like Allopath rather than plain aloe because it combines two important ingredients: the soothing effect of aloe combined with the nerve calming effect of PEA. So the aloe now understand that aloe's position in the icy world has fallen dramatically because we're phenotyping now, right? We're phenotyping. And so now that we know that there are distinct patient groups, we're no longer, telling everybody they need to do bladder therapies or everybody needs to do various supplements. Today, we go for more targeted therapy based upon your unique phenotype. So Hunner's lesion patients are going to have lesion therapies. And if we're going for a complementary therapy first, that's the lactoferrin group. If we're dealing with an estrogen atrophy patient, we're looking for something that will coat and protect the bladder. That's going to be chondroitin. If you're having a bladder wall flare, aloe has the ability to soothe some of that tissue. But over the long term, I do not believe that aloe can physically change much about the bladder. It's just soothing, and it's water soluble. And because it's water soluble, it dissolves in your urine and you pee it out. If you have pelvic floor driven symptoms, we're going to be focusing on things that are relaxing, like chamomile, which is a smooth muscle relaxant. Peppermint is a muscle relaxant. Smooth muscle, not skeletal muscle, but still something like that would be reasonable to do for a flare. If you've got pudendal neuralgia, where we're dealing with very, very irritated nerves and muscles, that's when we're going to go into the PEA type of products like Peora as first-line interventions. Of course, if you're bleeding, if you've got a high fever, if you're scared, anything at all like that, you immediately test your urine with a UTI test kit. Let's see if we're dealing with a UTI. And of course, if you need to, you go to the urgent care of your doctor. I mean, that's my rule. If I'm shaking and I'm scared, I go to the urgent care. I once had what I thought was a bladder flare for 6 weeks, and it was very, very severe. It was just getting worse, and finally, I started having bladder wall spasms. And a bladder wall spasm is agony because a bladder wall spasm happens often as the last couple of drops of urine come out of your urethra, and I would bend over the toilet. I couldn't move for like 5 minutes after these spasms. And I actually drove over to my urologist's office without an appointment, and I walked in crying. And they had never seen me cry. And I ran the support group. This was at Kaiser Permanente. They had never seen me lose it like I lost it that day. And they tested my urine, and I had a raging bladder infection. And I should have checked that in the first week. Instead, I let it go on for 6 weeks. So Joanna says, I think the drink had orange juice in it. Thank you for always responding to my questions. I found a new pelvic physical therapist this week, and I'm starting next week. Excellent, my friend. Excellent. Okay. Ann says her burning is inside the vagina. Okay. So if it's inside the vagina, then we're dealing either with estrogen atrophy or bacterial vaginosis, or in some cases, very tight pelvic floor muscle. A muscle that's working hard is a muscle that builds up lactic acid, and lactic acid burns. Do y'all remember, listen, I had a mega workout this morning. I am so proud of myself. I did 2 miles on the treadmill, and then I did a lot of weights, and I increased all my weights by 5. I was a beast this morning, and I know I always feel better when I go to the gym, first of all. But do y'all remember when we were young and they used to send us out into the field and we'd have to run around the track? And eventually, after a half a track or so, a half loop around the track, your legs would start burning. Okay, why? Because that's a muscle that's working hard. A muscle that's working hard builds up lactic acid. So you can have lactic acid built up in your quad, but you can also have lactic acid built up in your pelvic floor, and that can cause a burning sensation. So, and again, estrogen atrophy, bacterial vaginosis, or maybe tight pelvic floor muscles, but what that isn't is your bladder. Anne says, what are the symptoms of a urethral flare? Oh, a urethral flare is very sharp, intense pain, like somebody shoving a knife up your urethra while you're peeing. Okay? It is like, what was that? Oh my God, that was so bad. What was that? I have never had mild urethral pain. I have always had, when it happens, like a sharp, blistering, cutting sensation in my urethra. And every now and then it's just out of the blue. Etc. So that is the primary symptom of a urethral flare, just constant urethral irritation. Your urethra is very uncomfortable when you pee. If I put on a pair of underwear, wash and shear tied, within 5 minutes, I will definitely have urethral pain and vulvar pain because my skin is so sensitive down there. So there you go. Now, I am here as long as you guys have questions, so please feel free to ask any questions you have. Nothing is off the table. I am happy to talk about anything. I am right now working on a new newsletter for our, let's see, I've got 80,000 subscribers to our newsletter and forum, 80, 90,000, somewhere in there. And then usually I've got like 30,000 actually read what I do. Sometimes lower, we'll see. So I will be sending out an email tomorrow, and it's going to be a Thanksgiving email about things that you can do to try to get through your Thanksgiving. Along with some news, we're going to be talking, we haven't even talked about Lyme disease yet. Okay, so hold on a sec. We have to talk about Lyme disease now. So I had a patient call a couple of days ago who had wicked IC symptoms, just wicked. And she was doing very, very poorly. And she had been struggling for 20 years or so with Lyme disease, and her Lyme disease had affected her entire body. So what is Lyme disease? Lyme disease is an infection of a bacteria called Borrelia burgdorferi. I think it's Burgdorfer. It is, you only get it from a tick bite. And generally, if you catch that tick in the first 24 hours, you dramatically reduce the risk of being infected with this horrific bacteria. However, if that tick has been there for a significant period of time, the odds are, if you live in a Lyme disease area like I do, you have a very big chance of being exposed to this disease. How do you know if you've been bitten? Well, most patients get a big round red circle around the area of the bite. And if you have that, you certainly want to contact your doctor, because that shows a substantial bite. And number two, the odds are they're probably going to put you on some prophylactic antibiotics for a period of time to nip this damn infection in the bud, because you do not want this infection to progress and grow. What happens is the infection just basically takes root in the body and spreads through the body and starts to affect nerves, organs, tissues. I have my best friend's niece. She was bitten like when she was 18, and she became very, very fatigued, very non-functional, couldn't go to college. And of course, when you're the kid, you just want to know what's wrong. And there was all this kind of vague, well, maybe she's depressed, maybe it's this, maybe it's that. Imagine for a child suffering from a very, very severe infection to be told that it's all in their head. I'm going to tell you right now, a lot of Lyme disease patients face that, just like IC patients face that. Eventually, though, they did find that she indeed had a very bad Lyme infection. They knew exactly when it happened. She'd been hiking, I think, in the Sierras when she was exposed, but the damage was done. The infection is very pernicious. It's very, very difficult to treat. So the question then is, can Lyme disease affect the bladder? And the answer is absolutely. I mean, so if you're an IC patient and you know you've been bitten by a tick and you have other symptoms that we would associate with Lyme disease, and honestly, I think every IC patient who's going through a diagnostic process should probably be tested for it anyway. I know I was, because again, I live in a very high Lyme area. I still remember our veterinarian contracted Lyme disease, and he lost his career because of that when I was much younger. So several years ago, I had another patient contact the IC network to share her Lyme story. She was in her 40s, a mother of 3, and she was having absolutely disabling bladder symptoms for 5 years. She couldn't sleep, shop, drive, or go anywhere without having to use the restroom. She did not want to leave her house. So after her diagnosis of IC, she read about a possible connection to Lyme. And interestingly, she'd already had several Lyme disease tests done, but many of the older ones, are like Western blot, are a little bit more unreliable. So they ordered a new round of Lyme tests, like the IGeneX Western blot or the CD57 test. And sure enough, she actually did test positive for Lyme. And she believes that that infection caused her bladder disease. And I'm going to agree with that. So 70 to 80% of infected patients get that big bullseye rash. The symptoms of Lyme include itching, chills, fever, headache, fatigue, muscle, joint aches, and swollen lymph nodes. You can have abdominal pain. You can have diarrhea, vomiting, cramping. It can cause paralysis of the face. It can cause Bell's palsy. It can cause swelling of your large joints. It can cause headaches, sleep disturbance, and heart palpitations. It can also cause weird muscle movements and numbness and tingling and speech problems. It's challenging. Now, if you go over to any of the Lyme disease support groups, you're going to see that they talk about bladder symptoms. These patients do experience symptoms very reminiscent of interstitial cystitis, including frequent or painful urination and or symptoms consistent with a UTI. And very, very interestingly, one of our top IC researchers, his name is Michael Chancellor, when he was starting his first research years ago, he was looking at bladder biopsy samples of IC patients. And what did he find? He found Borrelia burgdorferi in some of those patients. I just went through the literature again, and we now have 2 new case studies that have been published of patients with Lyme disease, particularly young patients with Lyme disease. I think one of them was 6 years old. I think 6 years old, and the other one was like in their 20s, who had frequent urination, but even more interestingly, they had urinary retention. They couldn't pee, all related to Lyme disease. So in Megan's case, once they started treating the Lyme disease with antibiotics, her bladder symptoms improved dramatically. She shared, after 6 months of antibiotics, I have my life back. I will be in treatment for at least a year. I am not 100% yet, but my bladder is better. The urgency, frequency, most of the pain is gone. I recently took a 2-hour car ride and I did not have to ask my husband to stop so that I could use a restroom. So Lyme disease activists have been very, very vocal. You know, we have a lot of internet-driven mischaracterizations, misperceptions, things like that, where like in the embedded infection, people will come into an IC support group online and say, you all have an embedded infection. You all should be on antibiotics, which of course is ridiculous and ludicrous, because that does not explain why people develop IC while going through chemotherapy, or why people develop IC after they fall on their tailbone. We also have a group of activists who like to say, or who have said in the past, that IC is caused by Lyme and that we all have Lyme. And that, again, is very, very wrong. The IC Lyme connection is going to be very, very small. But it is important that you be aware of the fact that there is a connection. So if you live in a high Lyme area, if you have a history of being bit by a tick, or even if you don't, and you suddenly develop symptoms for no reason, it only makes sense to go get checked for Lyme disease. It only makes sense. As Megan wrote, I had been to doctor after doctor for all these years, and no one could figure out what was wrong with me. If only I would have known to make an appointment to see a Lyme literate doctor, I may have found the answers many, many years ago. Now, I will say that there was one more study. Researchers in Finland studied 50 IC patients to determine if they had the antibodies against the Lyme infection. And only 4 out of 50 patients, 8% of those patients, had antibiotics, and only slight levels. So again, that argues for the point that we can't make any broad generalizations that we all have Lyme. We don't. But again, you are an anatomical mystery to be solved. Our job is to try to understand what is driving your symptoms. And that means we have to, IC is a diagnosis of exclusion. We have to rule other stuff out to find and try to identify what is causing your unique symptoms. So it is absolutely worth talking to your doctor about Lyme disease and or potentially getting a test. There's a part of me that wants to say, I would bet you that one person watching this video right now, so we've got 30 people right now on both platforms, that one of you actually probably does have a Lyme and you don't even know about it. I would bet you that that's true. And look at this, Sue here. I was diagnosed with Lyme in 1987. She was sick for 7 years. She was treated with Suprax, doxycycline, Rocephin, and you had a PICC line. So Sue, did your bladder symptoms begin before or after the Lyme disease infection? Sue says Borrelia is a spirochete, not a bacteria. You know, Sue, I agree. And that was a question I had because I always have to refresh my memory. So yesterday as I was going through a lot because I was updating a blog on our website on Lyme disease. They were also talking about it as an infection, as a bacterial infection. And I will admit that I was a little confused by that, but you're right. All right, let me go back here. Anne says, I'm going to pelvic floor and using topical estrogen, you still burning. Well, that means that we've got to, it's going to take time. Nothing happens overnight here, hun. Nothing happens overnight. The bladder is the slowest healing organ in the body. So it takes time for the bladder to heal. And God forbid you be drinking coffee every day. It'll never heal if you keep pouring that acid on that tender tissue that's trying to repair itself. And our challenge here too is the vagina is, especially if you're postmenopausal, it's a very dynamic environment with a lot of different bacteria. You know, what happens is your pH increases with menopause, and as your pH increases, it becomes more hospitable to lots of different types of bacteria. That was proven by Dr. Ann Ackerman in her IC microbiome study. And so, you know, there's just stuff going on, my friend. There's a lot going on, but you just have to be persistent, give your bladder time, do everything you can to try to get your skin as healthy as you can, use that topical estrogen, eat well, et cetera, et cetera. You just have to do it. You know, I got to say, I was watching while I was eating breakfast this morning, a TikTok video that I thought was brilliantly insightful. And it was a teacher talking to children and talking about how powerful words are. And what she said is, if you're going to criticize somebody, give them something that they can fix in 30 seconds. So if if your fly is down, they can zip it up. If you got a shoelace that needs to be tied, they can easily fix that. And she was talking very specifically about how much harder words are and how painful criticism can be if you're criticizing something for somebody for something that they cannot change. You know, whether it be your hair color. I mean, I took a beating as a redhead in school. I mean, I will never forget what I went through as a redhead. On the color of your skin, a medical condition, a scar, anything at all like that. I thought it was really incredibly wise words. John said, I wonder if I should pursue the Lyme route. I live in a high-tech environment. John, dude, absolutely. You got nothing to lose, my friend. I would definitely check that out, just out of curiosity. Especially in your case, especially since, you know, we have such interesting feedback from your next-gen testing. I mean, granted, the next-gen testing didn't find it. I don't know if next-gen testing would find Borrelia in the urine. I honestly don't know. That's never come up. But I say you got nothing to lose. Why not get your blood tested just out of curiosity? Johanna says, does a heating pad in the lower belly help? Could it help with flare-ups? Absolutely. Especially for pelvic floor flares, because heat relaxes muscle. Listen, I live with a heating pad. I have a heating pad with me all the time. And I have to use it on my chest for my incisions, but we have a triangular heating pad that fits right over the pelvis. It is perfect. It is the perfect size. It will last for years. It weighs like 3 pounds, and that weight actually feels good. That warm weight over the pelvis is great. So heat relaxes muscles. There are some patients out there who don't want heat. They like ice. They like cold. So if you're one of those patients where heat doesn't work for you, that you need cold, what that tells us is your nerves are involved, because cold calms nerves down. So anyway, I would strongly recommend it. And we have I have one somewhere. You know what? Hold on. Hold on. I have a brand new one. Hold on. Here it is. So if you want to see, sorry about that. YouTube, tell me if the sound is okay, because I just knocked over your microphone. Okay, so this is the microwavable heating pad that is custom made for us by a retired woman here in my town. Actually, she lives in Sonoma. Love her. I met her at a Christmas fair. And I said, hey, can you make us a microwavable heating pad that will fit perfectly over the pelvis? And she said, yeah, I'd love to. And so we've been working with her for 15, 20 years now. It's a ginger bee comfort pack. And to give you an idea, so this is the shape. This is the shape of it. And so, see that? It fits perfect fits perfect over the bladder. Perfect. I love, love, love these. The ones that I use are probably 10 years old and they still work. So this is a great investment for anybody who's struggling with pelvic floor tension. I think it's like $28 because it's heavy. It's heavy. You know, understand my good friends here that postage is off the charts right now. And I know that it's, it's really tempting to buy on Amazon. And so we're the exclusive sellers of like this heating pad and bladder builder and bladder rest. I mean, they're made for us. I pay for the productions of those. And when Amazon says free shipping, it's not free shipping. It's free to you. They charge me for your shipping. And so we are taking a beating on Amazon right now with the rise in postal rates. And so when you buy something from the IC network, just know that you're helping us do this work. And it's better to buy in the IC network shop, and it's cheaper to buy in the IC network shop than it is on Amazon. But anyway, life. Business is hard right now for everybody. All right, Sue said, I feel like my bladder has more flares since I had COVID again last March, which has caused more long COVID symptoms. Are they seeing more issues with frequency, urgency, and long COVID, which for me feels like a battery that never fully charges or runs out of juice? I have stretches where I do better and then stretches where I do worse. You know what? Hold on. Let me look. Let me just go to the National Library of Medicine here, and let me just see if there's anything new. Anything new with COVID bladder cystitis? What's the most recent? Oh, look at this. Okay. So the answer is yes. There is refractory COVID-associated urinary symptoms that they have documented, symptoms that are not resolving. with, in some cases, increasing symptoms of frequency, urgency as long COVID sets in. All right, so here's a follow-up study from last year. Oh, done by Ken Peters, one of our top IC doctors and IC researchers, and Michael Chancellor, the guy we were talking about earlier, who found the Borrelia in some of his IC biopsies. You know, the first COVID cystitis reports came out in Germany about 3 months after the pandemic started. They published an article about all these new COVID patients who with no history of bladder issues, they get COVID. Now they've got really severe bladder issues. They called it de novo cystitis. Then the American researchers in Michigan actually went to their COVID cystitis, their COVID patients, where they too were able to confirm the onset of de novo urinary symptoms associated with COVID infection. We call this COVID cystitis. I've worked with many COVID cystitis patients now. So let's see what this found. Okay, hold on a sec. Let's look at this. Prospective follow-up on overactive bladder symptoms in patients with prior SARS-CoV infection. Twenty 3.8% of participants recorded a significant increase in urinary symptoms. And the symptoms didn't change. Here, hold on. The urinary symptoms didn't change for the first year. They struggled with severe symptoms for a year, while the PCR testing, finding COVID, got lower and lower and lower. But at that year, 71% of patients who were PCR positive for COVID, 43% of patients who were SCR positive for COVID, and 69% of patients still reported a significant increase in urinary symptoms. They conclude most COVID-19 patients experience a return to symptoms to baseline, indicative of a potential resolution of COVID-associated cystitis. However, a subset of patients did not, raising concerns about the underlying factors contributing to this outcome. Great. And I'm being sarcastic there. Okay. So, Sue, the research supports your experience. And I will see if I can dive into that a little bit more and maybe do an article on that, or even reach out to Dr. Peters and see if I can interview him on that. Liz says, I consume no caffeine, no coffee, no tea, no chocolate. Go to pelvic floor, do my exercises as recommended. Finally, after 7 months, I came out of my flare. I also take a lactoferrin. Most comfortable these days. You use heat all the time. Excellent. I'm so glad, hon. I'm so glad you're doing better. But I use heat too. The fact that you use heat really points to underlying muscle tension. Man, my neck was so tight yesterday because I've been working at the computer for hours and hours for the last several months. As I was trying to paint, I could feel, normally it's the left side of my jaw that starts to dislocate. I could feel the right side start to dislocate, and I had to stop and massage my neck really badly. So he is my friend. Sue said, what is a struggle? What is a struggle is there hasn't been any definitive treatments for long COVID. I do have a follow-up with Dr. Peters, but there's so many symptoms of long COVID. It's hard to know if my symptoms are worse from the days where I just get too exhausted to get up, not drinking enough, or what is actually happening in the body that causes the flares to related to long COVID. Anyway, so it really does make me think, because, I've had COVID twice now, and I, a year ago, had COVID that affected my heart, and I've been on heart medicine ever since. And I will say that I don't have as much get up and go as I used to. And like I got a good 6 hours of strong work in me pretty much a day, but more than that's a stretch. And most importantly for me, and again, man, we're just talking here. We're just talking here. I'm no expert in this. If I don't eat, I get really messed up. I mean, I will just shake like a leaf. If I haven't eaten in like 6 hours, it is ugly. It is ugly city here in Jill Osborne's body. And I have to eat now. I don't know. I don't know if it's aging. I don't know if it's my weird variation of long COVID. I just don't know. There's too many unknown questions here. All right, YouTube. Kylie said, can you explain to me about installations, please? My doctor recommended that I try that for relief. And Kylie, I'm sorry it took me so long to answer your question. I apologize. I had this screen hidden by the Facebook screen. Thank you, Rebecca. Rebecca says, I look forward to your chats. I've learned so much. Okay, so a bladder installation is when they put medicine directly in your bladder with a catheter. The big challenge with the bladder is if there's a bladder disease going on, like an infection or cancer, when you take it by mouth, you have digestion. And digestion destroys a lot of medication. Digestion destroys like the what we call bioavailability for Elmeron is like 5 to 7%. What that means is that 95% of it was destroyed by digestion. They only thought 5 to 7% actually made it to the bladder to do anything. So the bladder tends to be a fairly challenging organ to target therapeutically. It makes a lot more sense to put a medication directly into the bladder. That way, 100% of the medication arrives at the tissue in distress. And so we're now seeing a greater trend of putting antibiotics directly into the bladder through an installation where 100% will get there. Hold that thought, Paula. 100% of the medication will get into the bladder. And that's true for some cancer treatments like BCG, Bacillus calmette-guerin, which are bladder installations that are put into the bladder for bladder cancer. And that's also true for heparin and for Elmeron and for some of our bladder instills. Of course, the fundamental problem with putting it in your bladder is that you're going to pee it out. That's a problem too. So that means we have something called a dwell time. That when you have a bladder installation, generally we want to keep it in the bladder for a good 20 minutes to allow enough of the medication to kind of penetrate into the bladder wall and potentially do good things. Okay, so a bladder installation is a viable, important, and some would argue far more effective way of treating the bladder than a typical oral medication. So now in the IC world, when are we going to use bladder installations? Well, 20, 30 years ago, we all thought IC was a bladder disease. So we were all given bladder installations. I was given DMSO installations, which was DMSO is the only oral FDA approved medication for IC, but installation for IC, but it would never at this point in time be approved today, in my opinion, if you look at the actual research. But back then, they thought DMSO was a bit of a wonder drug. Didn't do a damn thing for me. Hurt, hurt a lot. Today, we now understand that there are distinct patient groups. So, and each group has their own treatment. So a Hunner's lesion patient has wounds on their bladder. So if their bladder is screaming in pain and their bladder is bleeding, as lesions are known to do, generally what they're going to do is cauterize the lesion and inject a steroid into the lesion. That DMSO had, if I remember correctly, absolutely no beneficial effect for a Hunner's lesion. It would probably just make things worse, certainly more uncomfortable. However, I have seen some doctors say you could use a heparin lidocaine installation for a patient with severe Hunner's lesions to just try to calm the nerves down and reduce the pain. Okay, and ultimately that's what installations do. They're calming and soothing. They don't fix the underlying problem, but they can at least ease some of those symptoms and kind of generally calm things down. If you've got estrogen atrophy, if you're in that bladder wall estrogen atrophy phenotype, we're dealing with a bladder that cannot defend itself well because you don't have enough mucus in there because you're older or you're on Lupron or you've had a hysterectomy and your bladder can't make that nice thick protective coating. And so for patients in that situation, they might want to do a chondroitin-based supplement. Or a hyaluronic supplement or a combination of the two, Hyaluril, something that will put a nice coating in the bladder. In the United States, that's usually heparin. We usually do heparin, though some doctors do Elmeron. So that's the most logical use of a coating type installation is going to be for the estrogen atrophy patient. If you've got chemocystitis, your cystitis is being caused by essentially a chemical burn of your bladder. Well, we got to figure out what's burning your bladder and stop doing that, whether it be ketamine or you drinking diet soda or Mountain Dew. Give your bladder time to heal. Again, a installation might be comforting and soothing to that tissue, but you'll never get better if you don't stop the coffee or the Mountain Dew. You got to allow your bladder to heal. It is physiologically impossible for your bladder to repair itself if you are pouring a strong acid on every day. It's impossible. The new cells trying to heal your bladder are very, very vulnerable to bladder. Gunvar, hold that question. If you are a pelvic floor driven patient, really the installations are probably not going to do very much. If you're a pudendal neuralgia patient, really same thing. They're not going to do much. That's my primary phenotype is pelvic floor, which explains why DMSO never did anything for me. And if you're in the widespread pain phenotype where we're dealing with nerve sensitivity throughout the body, the value of an installation really would be in just kind of calming the nerves in the bladder. So you would probably want to do a heparin lidocaine or a lidocaine installation. So it's basically, just to summarize, not everybody has a phenotype of IC that will respond to an installation. But if you've got estrogen atrophy, if you've got a bladder that's screaming in pain, doing something like a heparin lidocaine installation, I mean, we call it a rescue for a reason. It can rescue you out of a flare, that generally you can walk out of that doctor's appointment without pain and discomfort for a few hours. And then slowly, as you pee it out and as it wears off, the symptoms will come back. But the theory here is kind of that the more you calm the nerves, the better. And there's research to back that up. Generally, the protocol for, because DMSO really not done very much anymore. Thank goodness. I mean, it's pretty over. Very, very old school. The most popular bladder installations today are going to be the rescues. And the protocol for a rescue is really going to be 3 times a week for 2 weeks, and then maybe once a month for several months. If your insurance company, if your doctor will pay for that. Otherwise, it might be once a month for 6 or 7 months. Paula says your shaking is from low blood sugar. Oh, I'm sure. And my diet is so clean right now. I mean, I've lost almost 20 pounds in the last year. See The fat is gone. Yay! I'm almost back to where I was in college. I mean, like I'm like a few pounds away. Um, so I don't. I just have a really simple, clean diet, and the only thing that I mean, even if I'm eating chips, I eat unsalted tortilla chips. So I just forget to eat. I mean, yeah, and the other thing too. I mean, listen, I'm an old IBS patient from my 20s. I had horrific IBS in my 20s because I'm part of that widespread pain group. I mean, I had the IBS before I had bladder pain, and so I am not a foodie. I do not like food in the sense that a lot of people enjoy cooking, a lot of people enjoy going out to restaurants and trying new things. I am not in that group because I had so many years where I would go out to a restaurant or I would try something new and I would end up in the bathroom all night. And so I like simple, fresh, healthy food. That's it. I do like 2 rotisserie chickens a week. I do salad bar, I do veg, and I do panini rolls, and that's like it. I do. Although I will say I've been doing a few Twizzlers. I did it. I was like finishing the last part of our diet guide, and I was sitting here and I was struggling with my intro, and I was just like, I can't. I'm not saying it right. And I did get in the car and go to the grocery store and buy some Twizzlers. Deb says, I have essential tremors, head shaking. I've been diagnosed with a brain aneurysm, so it's a stress of all this. Girl, I have essential tremor too. That is inherited. And if you go back and you look at my videos, you can see I have videos where I'm doing this. That's essential tremor. And also for me related very, very much to having a messed up neck and neck tension. So I feel you, hon. I feel you. And I'm so sorry about the brain aneurysm. Yikes, girl. You're going through stuff. I was watching another video, and this was of a young woman who, because I don't have TV, guys. I don't have cable. I canceled the cable. And so I go to Netflix and I go to YouTube, after dinner. That's what I do. And I was watching a video on YouTube of a young woman who had had brain cancer, and she'd had several brain surgeries. Like her first brain surgery was like at 19, and then she had more at 24, and then her dad committed suicide, and then when she was 29, she had to have 2 more brain surgeries. And she finally said, I don't think I can do this anymore. How much is a person supposed to take? How much can I take before I break? Which is exactly where I was a year ago. How much more of this can I take before I'm broken? And she had a revelation that instead of being afraid of what was going to happen and thinking, I can't take it anymore, I can't take another thing, what she said is, I'll figure it out. If something happens, I'll figure it out. And so she changed the way she was talking about it from dread and fear, like this might be it, to, man, whatever happens, I'm going to figure it out. And that really resonated with me. And I was on the treadmill this morning saying that to myself, I'll figure it out. I'll figure it out. I'll figure it out. Because we get pulled into these moments of stress and frustration and worry and anxiety. I mean, the medical anxiety is real. So say that to yourself. The next time something like this happens, say, I'll figure it out. I am capable. I will figure this out. Crystal said, I just got prescribed trospium, but I'm afraid to take it. I've heard about urinary retention and now I'm worried about it. Well, let's look it up. Let's look up the side effects here. So trospium, adverse events, urinary. And we're going to go to a credible source, the Mayo Clinic or the Cleveland Clinic. We're not going to use AI, my friend, because AI gets things wrong. So trospium is used to treat the symptoms of overactive bladder. It is a urinary antispasmodic agent. Okay. There are a lot of meds that using this medication with any of the following meds, usually not recommended, but may required. So you're going to want to Google that. So look at this. Like you're not supposed to use it with Flexeril, which is commonly used with IC, with the opioid pain meds, which are commonly used. Okay. And like tramadol, things like that. So hold on a sec. Let's see. It is very important that your doctor check your progress at regular visits to make sure the med is working properly and to check for unwanted effects. It can cause angioedema, which is fluid that builds up in your chest and in your legs, all sorts of places like that. In high doses, patients can become dizzy, drowsy, confused, or have blurred vision. They don't want you to drive until you've taken it so you know how to react, because if you're not alert, you shouldn't drive. It can cause you to sweat less. It can cause your body temperature to increase. It can cause dry mouth, nose, dry throat. You can use a sugarless candy or gum, melt bits of ice, yada, yada, yada. Okay, so what are the side effects? Bladder pain, bloody or cloudy urine, decrease in the frequency of urination, decrease in urine volume, difficulty burning, difficulty passing urine, frequent urge. Okay. So this happened to me when I was given in my first year of IC, I was given oxybutynin, ditropan. Now, these are smooth muscle relaxants. Your bladder is made of smooth muscle, not skeletal muscle. So these are medications that are designed to try to calm bladder spasms, to calm that persistent sense of frequency urgency. And it works. But basically it works too well. And so what I very distinctly remember is by month 3 of me being on this medication, I started having trouble releasing urine. That it, in essence, kind of deadened that reflexive need to urinate or urination itself. And that made no sense to me. It was counterintuitive because I knew that I felt better when I peed and I wanted to pee quickly. And I didn't want to do something that would make it harder for me to pee. So here, let me look up one other thing real quick. I want to see the anticholinergic burden of trospium. Okay. So trospium matches the oxybutynin, the ditropan, the detrol as an overactive bladder medicine. They are what we call anticholinergic medications. And the challenge with anticholinergic medications is that they have a well-recognized risk of dementia and cognitive decline if used daily over time. And this is not just for older folks. This is for younger folks, even patients in their 20s who are using these types of strong anticholinergics, they have found decline in their cognitive abilities. So, and especially if you are older, if you're over the age of 50, they try not to prescribe these meds because we want to protect your brain, our brain, we want to protect it. So these anticholinergic medications have been phased out in favor of another medication which does the same thing but is not anticholinergic. It's called Mirbitric or mirabegron. And so the drug of choice now used for overactive bladder is not the anticholinergics. It is the mirabegron, Mirbitric. The challenge that we, and again, this is well documented. There are black box warnings now. We have large research studies that have linked in tens of thousands of patients the risks associated with this type of medication to cognition. The challenge is that these meds are cheap, and insurance companies like cheap meds. Mirabegron is expensive. They don't want to pay for that. So they will often just hand out these anticholinergic meds first. So I think you need to do some reading about it, and I think you need to, you can talk to the pharmacist about your concern. I don't know what their take is on it. I mean, you could ask them about the cognitive decline, but you can read about that online too. But you could also reach out to your doctor and say, hey, you know what? I'm a little afraid of this med. I've done a little bit of research. I attended a support group. They were talking about this type of medications and mentioned another medication called Mirabegron that is not associated with these great risks, and see if it's covered by your insurance, because I wouldn't worry about their Mirabegron at all. I mean, unless you happen to be sensitive to it. And of course, I can't tell you that. You won't know until you try it. So it's a good question. It's a good question. I know that when I experienced the urinary retention, it just didn't make sense to me. And I knew that when I stopped it, I felt better and I could handle my pain more easily. Kayleen said, I'm still in pain, but I'm so glad I'm not in the hospital. Urine feels like it's about to bust out of my urethra at any time. Why? Sounds like you're having, I mean, there could be a couple of things. It could be estrogen atrophy. But at your age, I wouldn't expect to see that so much, maybe. It may be that you have severe urgency. It may be that urine is kind of entering your urethra, making you feel like that. But normally we would see that in somebody older, not younger. I don't know why, honey. Unless you're drinking Gatorade. Inside joke. Sorry for yelling. Crystal said, I always feel sick when I'm in an IC flare. Yeah. Crystal, I used to have what I call sick all over days. I just felt so ill. And if somebody had asked why, I would say, I don't know. I just feel ill. That was before my IC started, when I was struggling with IBS and dry mouth and migraines and all that other stuff, that whole widespread pain. I was having a dinner with Dr. Lowell Parsons for our first IC conference, and he asked if I had a history of allergies, and I said, yes, believe me, I do have a long history of hay fever. And he said, we got this new antihistamine that we've been given to patients, and it seems to be really helping a lot of people. It's called hydroxyzine. You might want to give it a shot. And I'm like, yeah, I'll do anything. So, which of course is a very bad attitude, but I did my research. I read about it a little bit, went, okay, I'll give it a shot. And the very first thing that happened when I went on the antihistamine is those sick all over days dropped away massively. Instead of feeling sick 5 out of 7 days a week, it went down to maybe 1 day a week did I feel sick. And now that rarely happens. Sue says, going out to restaurants I find so hard. And if you ask the waitress if something is spicy, they don't really have a clue. To a person that has, I see what that means. So I always go for the safest choices. Again, maybe I'll take a bite from my husband to try something new. What's hardest for me was when my family would think I was just being picky. I'm at that point in my life now where I just don't care what they think. Yeah. I was at a family event last weekend, and yeah, the two of us have had our gallbladder removed, so we're not allowed to have saturated fat. And the younger generation brought everything made with butter. I was just like standing there with my sister, looking at her and looking at the food, and they're looking at us, and I'm looking at my sister going, "Yeah, we can't eat that, right?" She's like, "No, we can't eat that." It's like, and they were like, "Oh, we're sorry." How many times do we have to say it? I don't know. Well, you can't expect other people to understand your unique diet sensitivities. And this is why, as we ponder Thanksgiving, it's just really important to, in some cases, bring your own food. I mean, I'm going up again, and I'm going to bring food that I know I can eat. I just, it's unfair to expect family members to read your mind and adjust and adapt their family traditions just because we can't do certain things. But that's really not fair. We have to adapt. If you're going to grandma's house and she makes lasagna for Thanksgiving, for God's sake, bring your pre-leaf. That means that pre-leaf will reduce like 95% of the acid in the lasagna. You might be able to get away with it. Or, you just bring your little side dish, maybe pasta primavera without tomato sauce, and say, "Grandma, hey, I brought mine." And she's like, "Oh, I'm sorry, I didn't know." And it's like, "It's okay, Grandma. It's okay. We're fine." It's okay to bring food that you can eat and desserts you can eat. And here's the thing about Thanksgiving. I mean, there are like two fundamental things you got to understand about Thanksgiving. Number one, it is okay to stay home. This was just such an important lesson for me early on, and I've described this many times. My mother was the queen of guilt. Let me tell you, she had me wrapped around her finger for decades. And in her mind, she wanted the entire family together. She wanted us all to go this place and that place, or drive here or drive there together. And when I started having pelvic pain and bladder pain at 33, I fell for it a couple of times, and I kind of ruined some holidays because here I was feeling terrible. I had no business getting in a car going anywhere. Yet she convinced me to do it. And I would get to my sister's house and I'd have to go lay on my sister's bed all day. And then people are like, "What's wrong with Jill? What's wrong with Jill?" And then you hear the little, "Oh, isn't she better? Maybe this is all in her head." The things you think people, they might not be saying that, but you're laying there thinking they're saying that. And finally, I mean, I remember it. I remember it so well. I mean, I just took out all the emotion over the holidays, and I just said, "Listen," so people would invite me, and it's like, "Thank you so much for the invitation. I won't know until that morning. I want you to know I want to be there. I have every intention of coming, but I have to wait and see how I'm feeling that morning." And then that morning, when I got up and showered, man, I just rated my pain on a scale of 1 to 10. If it was over 5, I stayed home. If it was under 5, I allowed myself to go. And the first time I did it, and because this movie had come out, it's like a 3-hour movie. Might have been the first. Well, it was a really, really long movie. I ended up watching, but I just told my family, I said, I'm staying home. I am in too much pain. I am staying home. And of course, my mother's like, "Are you sure? We really want you to come. Come on, just put your clothes on. It's okay. You should come." And I'm like, "No, no, I'm going to stay home. I need to stay home right now. I am in too much pain. That drive would be very, very uncomfortable for me." And the whole like negotiation for an hour. "Come on, Jill, you should come. They really, you'll people will miss you." It's like, "No, I'm staying home. I'm staying home." And then finally got them out of the door in the car. They backed out, drove away, and of course I immediately burst into tears because like I wanted to be there. Like we want to do all of those things. We do. It hurts to be left out, whether we do it or not. It's hard to be alone on a holiday, but I will tell you that day, that was exactly the thing that I needed to do. And so I had my heating pad, I had a long movie, and they brought turkey leftovers back and it was good. And it's like, my mom walked in the door, "Are you okay, honey? We really missed you. You should have been there." It's like, "I'm fine. I'm exactly where I needed to be. I feel good right now." And so I just want to encourage you to take the emotion out of the holiday here for a moment and just ask yourself that morning how you feel. Would you go try to run a marathon on a broken leg? Of course not. Don't try to run a marathon on a broken bladder or broken pelvic floor. You get to come first. Now, of course, we can say, bring the holidays to you, invite people to your house. Then you don't have to go anywhere. Make it a potluck. Then you don't even have to cook. The best solution is to bring them to your home. But if that's not possible and you can't clean your house and yada, 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 it's okay. It's okay to stay home. What I would not do is make a long car ride. I mean, a half an hour was torture for me back then. I can't even begin to imagine having to drive 5, 6, 7 hours in a horrific bladder flare or pelvic floor flare. That drive, it's gonna hurt. If you are gonna try to do that, bring a muscle relaxant, bring your get your body heating pad. It'll last for 10 hours. Put it on your underwear, it'll give you heat that way. Hopefully you're not driving. Maybe you can take a muscle relaxant to chill those muscles out for the drive. But it's okay to stay home. The last time I stayed home, I had my last period before menopause, and it hit. I was all dressed and ready to go, and I had a gusher. Like, whoa, where did that come from? And the cramps were insane. Like I had my red velvet dress on. My best friend was here. My family was here. We were all driving to the restaurant, and then, whew, a gusher. And I backed out. Everybody else went. I cried. It's okay. And I stayed with my heating pad. I got my family. People looked at me with disgust. I didn't care. That's who said. I didn't care. If I'm in pain, I'm going to protect myself. Now, here's the other thing about Thanksgiving. It's perfect for an IC diet. It's perfect for an IC diet. This is the time of year where there is a lot of food that you can eat. Turkey, fine. Just don't put a salt brine on it. Don't put spices on it. Like have a roasted turkey, put some butter or olive oil on it. You're good to go. Stuffing, usually fine. You can cut back a little bit on the onion. If you don't like the onion, that's fine. You can do corn stuffing. You can do wheat, sourdough, etc. I wouldn't do a hot, spicy stuffing. Maybe pass on the sausage stuffing. Mashed potatoes, fine. Green bean casserole, fine. Although the onions on top might be an issue, so leave the onions off. Pumpkin pie, you're good with pumpkin pie. You can back off a little bit of the cinnamon. Some people are a little bit more cinnamon sensitive, others aren't. Yam, sweet potatoes, you're good to go. Salad, you're good to go. Put the salad dressing on the side. Butternut squash soup, pumpkin soup, perfect. Those are going to be fine. So don't worry so much about the foods coming up over this holiday season. Obviously, you're going to back off on the cranberry. We're not going to do cranberry. We're not going to do orange, right? Just simple, fresh, healthy food. you should be fine. This is the best time of year for those of us who have been more food sensitive. The only thing I'm gonna say to pass on is chocolate. Inevitably, there's even gonna, at least we always had when I was younger, little nut cups and M&M cups that my aunt would do. You know, obviously they're all gone now, but we would get these little paper cups with salted nuts and M&Ms and we would all snack on those before dinner. Just pass on the chocolate. Pass on the chocolate. Because chocolate is neurostimulatory. Chocolate is a really big trigger for me, so I haven't eaten chocolate in years. If you want something that is chocolate-like, get some carob instead. I mean, I got a frozen yogurt yesterday and put a few carob drops on it. It's fine. No caffeine in carob. Deb said, surgery on the 10th. I'm scared, Jill. Also, my pelvic floor is off the charts. Stress, hypertonic. Oh, honey. You've got this, girl. You've got this. You're going to be fine. Walk into that head held high. You've done nothing wrong. This is about healing your body. So you got to do your affirmations. I can do all things through my faith, which strengthens me. Every day in every way, I am getting better. I will figure this out. We will figure this out. But use those affirmations. Kayleen said, I don't feel like eating either. I think this is the worst flu I've had in 6 years. Yeah. Crystal says she feels like she's breaking right now. Crystal, we should talk, honey. Would you call me tomorrow? Let's talk. Joanna says, I'm taking Myrbetriq, oxybutynin, and amitriptyline, using estrogen, Valium for pelvic floor pain, and still don't feel good. Honey, why would you be taking Myrbetriq and oxybutynin at the same time? That makes absolutely no sense, because they do exactly the same thing. And the oxybutynin comes with a lot of side effects. So you need to talk to your doctor about that. There's no reason to be taking both of those meds. The other challenge here is amitriptyline, and these meds do come with, the oxybutynin and the amitriptyline come with a bunch of side effects: dry mouth, dry eyes, weight gain. You start craving, you start snacking a lot and craving snacks. Most importantly, amitriptyline is known for messing up your heart. It can give you tachycardia. If you're somebody who gets tachycardia, arrhythmias when you take some allergy meds, some Sudafed, then amitriptyline might not be the right medicine for you, and that could be one reason why you're not feeling as well. You should, if you want, you can call me this week and we can kind of go through stuff. Anne says, why is hydroxyzine given? It's given for people who have a history of allergies. You know, one of the ways that we describe people who have a damaged bladder wall, not everybody, just people with a damaged bladder wall, we describe it as mosquito bites in the bladder. So think about it. When you get bitten by a mosquito bite, what happens? The mosquito injects venom under your skin, and then the mast cells in your skin react to that, and they release something called histamine. And it's the histamine that makes that mosquito bite red, swollen, and itchy. Well, that's what happens in the bladder when urine gets into the bladder wall. We have mast cells in the bladder wall, and those also become very, very irritated. And so using an antihistamine is one way of calming that irritation. And so it's one of two things that we do when we're dealing with a persistent bladder wall injury. So think about somebody with a Hunner's lesion, or somebody who has an open wound in their bladder, a persistent open wound in their bladder. So urine goes into that wound every day, multiple times a day. And that urine, when it gets inside the bladder wall, causes two things to happen. Well, three things to happen. It's a foreign body. Number one, these chemicals in urine are not supposed to be inside your bladder wall. The mast cells in your bladder wall release histamine, and the histamine then irritates a nerve. So now we've got neuroinflammation and we've got mast cell induced irritation, right? And your bladder's not passive, it's active. Your bladder wall is telling your immune system, help, help, invader, invader, invader. Please come, help, something's wrong. And so your immune system sends a whole bunch of white blood cells, lymphocytes to your bladder to try to find the invader, to try to find infection. But the thing is it's not a living invader. It's not bacteria. It is a chemical invader. It is a chemical injury, a chemical trauma to those tissues. Urine has now penetrated into that tissue. So the white blood cells have nothing to fight. So they're just swimming around there looking for whatever, but we're still dealing with a lot of persistent irritation and inflammation in the bladder wall from urine getting where it shouldn't be. So how do we calm that? Well, if we could seal the ulcer so it wouldn't happen in the first place, that's great. That's why we cauterize ulcers and lesions. That seals it, it closes it up. We can do the antihistamine to calm the mast cell inflammation, and we can do the low-dose antidepressant, the amitriptyline, to calm the nerves down. But neither one fixes it because the underlying problem is the fact that urine is going where it shouldn't go. We got to fix the bladder wall to stop that. We got to treat the lesion to stop that. That's why the number one cause of severe intense pain in the IC patient are untreated Hunner's lesions. And that affects roughly 5% of the IC patient population. Some would say 10%, but if you're ever diagnosed with Hunner's lesion, your immediate question is, what are you going to do about it? A bladder installation does not treat a Hunner's lesion. Botox does not treat a Hunner's lesion. What treats a Hunner's lesion is cauterization to seal it up, or a steroid injection, or lactoferrin. We've got the lactoferrin study from last year that showed that red inflamed bladders became pink and healthy. So usually with patients who are newly diagnosed with lesions or a very, very severe bladder wall, we're going to, at least I say, consider the lactoferrin as a kind of a first line intervention before going to the big stuff, more dangerous treatment. Sue says they took the warnings off using oral estrogen and testosterone for menopause, saying the research is old and people should not be afraid of breast cancer. I'm just wondering what your thoughts are on this, that I do use a small amount of estrogen cream, but I've read menopausal women should be using some testosterone, but there's been some pretty different things being said in the health sector with the new administration. I don't know who to believe. Well, I'm not going to believe a damn thing that is being said right now. I'm just not. I mean, they've fired some of the single most important researchers and consumer advocates. So I'm very, very distressed by what's happening. Our IC research is at a total standstill. I was supposed to collaborate on a Center for Disease Control grant this year. That's dead in the water. What's happening right now is heartbreaking. That said, the removing the cancer warning from oral estrogen is actually supported. Actually, let me take that back. Removing the cancer warning from topical estrogen is strongly supported by research because topical estrogen is not known for penetrating into the bloodstream to travel to other places to cause cancer. They also took warnings off of oral estrogen, and the science kind of supports that too. The New York Times did a fabulous investigative report that talked about how that black box warning appeared in the first place. That there was a researcher who grossly misunderstood the research, and he set out the warning call: estrogen, cancer, estrogen, cancer, and it turned out he was off by a fraction of 100, something like that. So I don't quote me on the exact numbers. I don't remember what the exact numbers were, but he was saying like, just as an example, 25% risk of cancer when it was actually a 0.25 risk of cancer. I'm not saying that was the exact number, but that was the degree that he was off. And at that moment, millions of women were taken off of their estrogen that was actually helping them function, because for some patients, menopause is brutal. Some patients have challenges with memory and cognition. Some patients have trouble. I had terrible muscle cramping, horrific muscle cramping when I was in my late 40s, early 50s. That's why I went on oral estrogen, and it stopped immediately. Um, uh, Speaking as a patient who now has breast cancer, or who had breast cancer, depending upon who you talk to, I mean, basically they cut it out of me. I don't want anybody to go through what I went through, because it broke me. It did. It really did. Cancer, to be told that you have breast cancer from a routine mammogram, literally in a heartbeat, your life is forever changed. And so, my mother took estrogen up to her 90s. She never had a damn problem with it. And I thought, it was fine with her, so it should be fine with me. And because I took estrogen for 3 years, I had to have a hysterectomy because I started bleeding. They thought I had uterine cancer, and then I had breast cancer. And yeah, that happens to some people. So I think really it's about the degree of your symptoms. If you have very, 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 very intense menopause-related symptoms, being on an estrogen for a year or two might be very helpful. But thinking of it as a long-term strategy, the recommendations before whatever the hell they did, that if you're over the age of 60, they really don't want you starting an estrogen. But I just don't want you to go through what I did. Do I regret taking oral estrogen? Hell yeah, definitely. As I said to the guy that I've been seeing, he's a lovely man with prostate cancer. I just said, listen, I'm broken. I have no breasts and half a vagina. I am not a catch for you. I mean, that's exact. And then I flashed him and went, look, there's nothing there. And he kind of laughed and looked at me and said, Jill, that's not why I'm here. I don't care about that. And we were together on Friday night playing games, and we were talking about his prostate cancer treatment, and I was just laughing. It's like, sex, yeah, no, it's not going to happen right now. Okay. Anne says, I was given Mirbitric, afraid to take it. Dementia, honey. And that's the point. Mirbitric is not associated with the dementia. Mirbitric is preferred because it is not an anticholinergic medication. Crystal said, thank you for explaining this. My IC isn't triggered by diet. I've been in remission over a year and ate anything I wanted, so I don't know what my IC is caused by. I'm going to suggest Mirabegron to my doctor. There you go. Hold on. Let me check on YouTube here real quick. All right. John said, traveling out of town for the first time in 6 years to go to University Medical Center. How can I stop the inevitable flare? John, body heating pads, muscle relaxant on board. And if you've got a little bit of pain meds, you'll get there. And honey, I've got your back. I want you, as you're in that car driving, I want you to pretend that I am sitting right next to you, holding your hand, looking at you going, we're going to do this together. We're going to do this. You're going to do this. And I'm so proud of you for going for it, my friend. Just go for it. I'll figure it out. You'll figure it out. But I mean, really, John, listen, you and I, we have talked a lot over the years. You see my face right now. I just literally want you to pretend that I'm sitting right next to you, holding your hand on that trip, okay? And I'm squeezing it really hard when I need to, just to get your attention. You can do this. Corey said, did we already discuss the Lyme research? I'll be watching what I missed later. But yeah, we've got 2 new case studies with Lyme disease showing that acute Lyme disease can cause, obviously, urinary frequency, urgency, and most importantly, urinary retention. So patients who are struggling to empty their bladder. And these were young patients. One of them was 5 years old. The other one, I don't remember the other one, like in their 20s, I think. Deborah said, and so Corey, let me just summarize by saying, for anybody out there, you live in a high Lyme area and or you have been bitten by a tick and your urinary symptoms developed after that, please go get checked for Lyme, because number one, we don't want a Lyme infection to go uncontrolled because it's so devastating over time. For decades afterwards, it can affect somebody, just like Epstein-Barr. The Epstein-Barr monovirus just got linked to lupus. I was reading this morning. And so we don't want your body to be ravaged by a spirochete that, cause horrific systemic effects over time. So just rule it out. I mean, if you had a history of a bite, etc., just go get yourself tested once and for all so that we know. And especially if you're having persistent infections. I mean, it would be really helpful to Google symptoms of Lyme disease so that you understand the other things that can happen: fevers, fatigue, etc., tremors, things like that. If you're having any of the other symptoms in addition to your IC, all the more reason to just go ask. Deborah said, I went in for pelvic floor therapy. They're focused on my bowels. They won't do anything with any wands. So far, 3 appointments. They haven't checked my pelvic floor and have me doing Kegels. What? Kegels are not used for pelvic pain. Kegels are used for incontinence. So if you're fecal incontinent or urine incontinent, then yeah, we want to strengthen those muscles with Kegels. But if you don't have incontinence, if instead you've got tight, painful muscles and urinary symptoms, then we want to do the exact opposite of Kegels. We want to be relaxing these tight muscles. We don't want to tighten them further. Sue said, I'm having a very down day with bladder pain, migraine, fatigue, feeling very overwhelmed because I'm supposed to have my children and their spouses here for Thanksgiving. It's giving me a lot of anxiety. And that was my mother also. And in my head, I feel like I have to do this holiday or I'm going to let my family down. I feel it's time to pass the torch, but I know they're not ready to take it. Sue, girl. Sue, it is not your job to rescue your adult children. They are adults. It is not your job to rescue your family members. And if you believe that it has to be perfect or you're going to let them down, you are putting tremendous unnecessary stress on yourself. Listen, people don't remember perfect holidays. People remember funny, eventful holidays. That's very, very true. You going for perfection is not going to help anybody remember this day. You instead saying, hey guys, listen, need a little bit of help. I need y'all to bring something. Bring your favorite dishes. Because we are passing the torch, my family. We are passing the torch. Come on over to my house. I'd love to have you here, but I need you to bring food because I cannot do it all for you right now. And I remember when my mom did that with my sister and I, and she was capable of cooking. She would have cooked, but she's like, nope. Y'all need to step forward and do it now. So stop trying to be perfect. You don't have to make a perfect holiday for anybody. And you know, let them know next year you want it at somebody else's house. You're getting older now and you have health issues now. Another way of thinking of this, again, people remember the funny things. So I remember the first time I made lasagna, I left the paper on the cheese. And I gave it to my sister and her family. And they're serving up the lasagna, and they pulled out these big pieces of paper. And they called me and they went, Jill, did you forget to take? And I was like, oh my God, I forgot. We'll never forget that. Or the time my grandmother made weevil soup. She made soup with turkey leftovers, and at my aunt's house, and my cousin Susie was there, and she was the first one to look at the soup, and she saw caterpillars in it, and she picked it up and she went, guys, what's this? And they realized their turkey soup was filled with weevils, and they threw it away, and grandma made another batch and it had weevils. So just enjoy the funniness. And, you know, listen, if somebody drops a turkey, no big deal. You know, everybody's going to remember that time. Hey, remember when Jill did that? Take the seriousness out of it. Bring the joy and laughter into it, my friend. Crystal said, I started using a TENS unit. I think it's helping with urinary frequency urgency. Good. Lots of people use TENS units. I used a TENS unit for many years. The hard part about TENS units is figuring out where to put the pads. So hopefully they told you where to put the pads. Oops. Get back up there. Okay. So this book, Ending Female Pelvic Pain, was the first book that talked in depth about how to use a TENS unit. And she has pictures in here of where to put the pads. And I can show them to you if you'd like to see this. Okay. So for some people, they put the pads down the back. So you can see that picture down the back. Get my finger out of the way. Let me see what she said on this. Along the spine to the side of the pain, which helps reduce low back pain, hip pain, and general pelvic pain. Or you can do 4 on the lower back, like this. Or this one is 2 on the lower back and then 2 on the glute muscle. And so the lower back ones are to reduce sacral pain, low back pain, hip pain, and pelvic pain. Pads go on either side of the spine in the low back area. And then the one where you've got low back and the glutes, that's also for sciatica. This one, I'm going to put my finger in there because I don't want to get banned. The pads are on the low back, but then also at the base of the butt cheek. And I can't really show that to you. I don't know if you can see that or not. So right at the bottom of the curve of the butt cheek, like at the top of the legs. Oh, darn it. I just showed it to you. Okay. Or you can put it on the front along the bikini line. And the one along the front on the bikini line, that's specifically for the bladder. Helps reduce pain with sitting, pain with positional symptoms, bladder pain, generalized pelvic pain. Place the pads in a semicircle near and around the pubic bone and hip bone. So if you're looking for more insight on where to put the pads, you can get this book, Ending Female Pelvic Pain by Isa Herrera. You can get this on Amazon. I have to find mine. You know, TENS units are really cheap. You can get them. The hardest part, the thing you have to understand about a TENS unit is it uses a mild electronic pulse to kind of re-regulate the nerves. It should never hurt. More is not better. So if you put a TENS unit on and you turn it up a little bit, you stop at the moment that it starts to hurt and you pull it back down. If you're doing a TENS unit to the point that it's causing you pain, you're running the potential of damaging nerves, and that is not a good thing. Carrie said, medication isn't the answer, otherwise it would work. But of course, maybe we keep trying. Maybe the condition is a teacher teaching individual. Okay, teaching us who. You said that really well, honey. Johanna says, I had to check mine because she didn't check my pelvic floor. I saw her 5 times. I'm starting a new person. Mary says, I cannot sleep. What can we take that doesn't throw us into a flare? Mary, we got to figure out what's keeping you up, what your phenotype is. So, most commonly, difficulty sleeping and running to the restroom is related to the nerves in the bladder wall being irritated for some reason. So we now have to figure out why the nerves are irritated. The nerves are going to be irritated if you're eating or drinking something strongly acidic, especially if you're menopausal, because your bladder can't defend itself from those foods. I will tell you, I woke up at 3:30 and I couldn't get comfortable. I sleep in a recliner. I don't sleep in a bed because I've got my jaw dislocates if I lay flat. And another thing I noticed with menopause is that sometimes you just wake up after 3 hours. That's happened many times to me over the years. I mean, I'm 65 now, where at least once a month, I'll wake up at like 3:30 and I'm up. I just wake up. And that's very common with menopause as well. We have in the IC Network shop a couple of things that might help, though. Here they are. So, because sleep is such a big problem, I started working with another company called Life Seasons, and they have a couple of sleep aids. So Rest ZZZ is a melatonin-free sleep support product. It's got magnesium, GABA, passion flower, chamomile, valerian. Of course, chamomile is the most important one. So quite a few patients have tried this. This might be worth trying. We also have a melatonin-based supplement that's called Relieve RPM. And then the other thing we have, because anxiety is such a big issue, anxiety gummies. And so these I just brought them in last summer. I don't have a lot of feedback on these. It was more just, let's see if anybody finds it helpful. I mean, they've got good track records and it's a good company, but we don't have a lot of data in the IC community for products like this, but Deborah said, problem there is no one else in my area. These people I see are pelvic floor therapy only. Okay. Johanna says, what's a replacement for chocolate? Carob. CAROB. Carob is fantastic. The phone number for the IC Network is right at the top of our webpage. 800-928-7496. Sherry says, would those areas for the patches work on men as well? Yes, they would. But she's got, okay, here, hold on. Let's see. She has a companion book called Ending Male Pelvic Pain. Okay, so this is the companion book. So let's just, out of curiosity. Okay, 257, 258. Let's see if she has corresponding pictures for men. She does. Yes, she does. So we've got up the back and on one side, if you're more side specific, we've got the 2 on the lower back. We've got lower back glute. Oh, this is a much better picture of the pudendal nerve. So with this one, you can see we've got lower back and our second pads are right on the inside base of the glute muscles. And then on the front, we can see that they're in an angle, a curved bikini line down here. All right. Diane said, I had my steroid shots in my bladder and the doctor gave me better pictures of my bladder. Excellent. The bladder pictures are in color, but I'm not sure what I'm looking at as far as Hunner's lesions. I've had my last doctor say I didn't have lesions and another doctor say I did. So I'm not sure. Well, honey, you can show them. You can show them to me if you want, or I can show you pictures of Hunner's lesions so you can see what they look like. We can FaceTime if you want this week. Crystal said, how can I call you? The number, please. I'll type it in here. Right on the front page of our website. Sue said, my mom had estrogen-driven cancer twice, but without it, the medication they put her on to make her have no estrogen in her body is what caused the resistant UTI and actually caused sepsis and her passing. It's hard to know what to do. Yeah. I'm not on any, I mean, it's kind of a damned if you do and damned if you don't situation. That's why cancer is so hard. You know, I asked my doc, it's like, why me? Why me? Because like I'm the only one on both sides of my family to have estrogen-driven cancer. I also happen to be the only one that worked in a lab. Well, my sister worked in a lab too, but I worked in a drug lab with a lot more toxic stuff. And what she said is that only 15% of breast cancer is genetic. For the rest of us, it's environmental exposure combined with periods of very, very intense stress. Stress is the catalyst that often triggers cancer to grow, along with sugar. And I truly believe that it was stress that triggered my breast cancer. Just trying to keep my parents alive during COVID and then watching them die was just, and having really no help was hard, very, very hard. Caregivers are very special people. I have no regrets. I love my parents, but damn, it took a toll. Thank you, Deb. Deb says, that's so sweet. He sounds amazing. He's a very, very nice guy. I'm just not ready. I'm still in wounded bear cave mode. You know, I'm just trying. I mean, I think I'm like 50% better, but I'm not strong enough really emotionally to handle and commit to a relationship. I'm just not. I'm getting better, but this is hard. Deborah has no incontinence, and yet they have you doing Kegels. So Deborah, that's somebody who's just not trained correctly. If you look at our national guidelines, Kegels are not to be done for patients who have IC. It sounds like you have a physical therapist who has not received the proper training for this. There is a great website called Pelvic Rehab, pelvicrehab.com. That's short for rehabilitation. Pelvicrehab.com is the database that you go to find physical therapists who have been properly trained. So it makes no sense that they have you doing Kegels when you have no incontinence. It's also interesting to understand why they're focusing on your bowels. That's interesting too. Johanna says, does black tea cause bladder problems? Hell yeah, girl. Definitely. Black tea is high in acid and caffeine. Black tea, green tea, white tea. Green tea is worse than black tea, but black tea is pretty rough. Deb says, how do I find pelvic floor relaxation exercises? I'm hypertonic. You can find them right here in our flare management guide. But that's not enough. You got to work with a physical therapist to try to identify which specific muscle is the problem and to give you some individualized exercises too. But our pelvic floor area has the various things you can do to relax your pelvic floor. A lot of suggestions in here. Deborah said they have me doing Kegels to help with the urgency. Well, it doesn't make sense to me. And if you look at our national guidelines at the American Urology Association, Kegels are not recommended at all. They are discouraged. So I have a feeling you're seeing somebody who might not have had the pelvic pain physical therapy training. It sounds like you're seeing somebody who might have had the incontinence therapy and they think they're pelvic specialists, but that's just not normally done. Crystal said, I was in remission for over a year, got a UTI in October. I've been in a flare ever since. Just so exhausted, working full time, taking care of my kids. Daily activities are becoming overwhelming. I just feel so defeated. This is breaking me mentally. Yeah, honey, listen. It's hard, but you're going to figure it out. So you had a UTI. They found the UTI. The question now is, did they treat the UTI completely? Or is there any chance that you still have lingering infection that could be causing some of your urinary symptoms? It is. So concept number one here is the infection gone? It would be perfectly reasonable to have another urine test to make sure that it's gone. And in the same sense, we want to make sure that you haven't picked up a fungal infection from the antibiotics, because when you take antibiotics, you create the perfect environment for fungus to grow. And so it's very common for patients who have been on antibiotics to get candida, and candida in the bladder can be very painful. But the fact that daily activities are becoming overwhelming really concerns me. If you've had 2 infections in 6 months, 3 infections in a year, that means you're in the complex recurring UTI group. And that requires a bit more treatment, a bit more diligence. And we always want to ask, why is my body vulnerable to infection? What is it about my body that is making me more vulnerable? And the answer for many, if not most women, is estrogen atrophy. That as your estrogen levels drop, whether you're on Lupron, whether you're on birth control, or you're just getting older, or you happen to come from a family where women go into menopause in their 30s, as those estrogen levels drop, your bladder's ability to defend itself from infection drops also, because your bladder should have a nice thick coating of mucus, and that thick coating of mucus acts as a barrier. It pushes bacteria away, pushes urine away, but it's estrogen dependent. So normally when you're young and have a lot of estrogen, you have a lot of mucus. But if for some reason you're estrogen compromised, then your mucosal layer gets thinner and thinner, which means it's easier to get infected. It's easier to get irritated. Now, we've had a lot of research done. I attended a class at the National Institutes of Health several years ago, taught by Dr. Anthony Schaefer, where he's talking very, very specifically about recurring UTI. And they have studied this extensively. They have taken daily urine samples. They have taken daily vaginal swabs. And what they found is that 24 hours before the bacteria arrives in the bladder, it's usually living quite happily in the vagina. And this then led the researchers to ask, well, wait a second, what's happened to our vaginal defenses? Why has our vagina become a safe haven for bacteria? And the answer goes right back to estrogen atrophy. So generally, if you're in this group, in addition to giving you antibiotics, it would normally give you a topical estrogen to use vaginally to boost your defenses there. So it is no longer a safe place for bacteria to grow. Okay. Sherry said, I once made a cake at my parents' home in a 9x13 pan. When I pulled it out of the oven, the plastic see-through cover was no longer on the cake pan. It melted onto the cake. That's a good one. Lori said, what are the pads called? They're just TENS unit pads. Or electrode pads. Sue said, as you know, I fully understand about that with caregiving and then the COVID, and it did affect my health. I can't say I would change what I did for my parents because I don't know the outcome. Yeah. Understand. Diane said, great. I can FaceTime on Wednesday if that works for you. I think I could email the pictures too from my patient portal ahead of time, or you could just respond back. That's fine. You can email me or you could sign up for coaching, either or. Sue said, I'm shocked at how many doctors still recommend doing Kegels if you aren't leaking. I was told to do them for years. Now I have an amazing pelvic floor therapist who's taught me how to relax those muscles. And most urologists don't take enough classes on tight pelvic floor. They're just used to treating incontinence. Absolutely, my friend. Absolutely. You nailed it. Nailed it, nailed it, nailed it. Now, if I remember correctly, I think on Friday, something interesting crossed my desk. Hold on a sec. PubMed. Here it is. So hold on a sec. So we have, now that the government shutdown has stopped, now they are finally updating the National Library of Medicine again, and specifically the National Center for Biotechnology Information, which is interesting. So we have a couple of new studies, 4 new studies here. The first one is the bladder trigone, which is that triangle of tissue between both ureters and the urethra. And as say here, the bladder trigone is an anatomically and functionally distinct region within the lower urinary tract, characterized by a dense network of afferent sensory fibers, specialized urothelial interactions, and prominent mechanotransduction mechanisms. In other words, it expands and contracts. Its intricate neuroarchitecture enables precise detection of bladder filling and the coordination of urination. Whereas when these pathways are dysregulated, this contributes to urinary symptoms like urgency, frequency, and pain. Despite its recognized clinical relevance, the structural and functional basis of trigone sensory signaling and its role remain incompletely understood. This review synthesizes current evidence on trigone afferent nerve organization. We call this a basic bladder study. I mean, there's just so much about how the bladder behaves that we just don't understand. Like, how does it expand and contract to pee? I mean, this is kind of what this is talking about. Anyway, they conclude that the bladder trigone is a critical sensory hub where nerve, urothelial, and immune systems converge to regulate bladder sensation. Understanding its molecular and structural specialization may inform the development of neuromodulatory therapies targeting sensory urgency. All right, well, that's interesting. Here is a study on profiling Hunner's lesions. Okay, that's not particularly helpful. Let me go to the next one. Effects of intravesical cocktail instillation on outcomes and serum pain factors in patients with IC. Let's see what they say about that. God damn it. So what they did is they combined DMSO and chondroitin and heparin into a bladder installation. All patients were treated with amitriptyline and a local installation of these drugs. And then some either got sodium hyaluronate or this combination of DMSO, chondroitin, and heparin. Patients in the latter group did much better. This was done in China. I don't know. I'm not on the DMSO bandwagon. What else do we have here? The use of intravesical hyaluronic acid. Okay, let's see what this one says. That's also from China. Hyaluronic acid instillation significantly, here, hold on. Okay, hyaluronic acid used for 6 months, 4 weekly, followed by 5 monthly. Okay. All studies reported statistically significant improvements in bladder symptoms. However, some bladder pain and storage symptoms persisted, and the bladder wall had not improved after treatment. Okie dokie. Let me keep looking. Let's see if there's any gems in here. Oh. So one, I actually did an article on it. Pelvic organ prolapse. Many women that we've worked with over the years have what we call POP, pelvic organ prolapse. What this means is that their muscles have gotten very weak, or a ligament has broken, and things are starting to fall out of position. Normally your uterus is held in place by some ligaments and good strong musculature. If you were lifting heavy weights, if you were straining badly, if you had a baby that tore muscle, things like that, what happens is you can weaken these muscles to the point that things start to fall. And they don't just fall, sometimes they bend over. So like if your bladder is supposed to be like this, which allows easy to drain, but all of a sudden your bladder goes like this, it's going to be harder to pee. It's going to be harder to empty your bladder. And when it's harder to empty your bladder, urine sits in there longer, and that causes all sorts of other problems. So we did have a new study come out earlier this week, and I did just put a blog up on this on our website, that firmly established that prolapses can cause urinary symptoms and IC-like symptoms. And that when the prolapse is repaired, urinary symptoms generally improve substantially, like at the 75 to 85% mark. So, over on the IC Network website, our most recent blog, which literally I just put up 2 days ago, new study links prolapse with IC symptoms. A cystocele is when the bladder starts to fall. A rectocele is when the rectum starts to fall. A uterine prolapse occurs when the uterine starts to fall. And then there's also something called an enterocele, and that's when a small portion of the bowel starts to bulge into the pelvis where it's not supposed to be. So a pelvic organ prolapse can be diagnosed with a pelvic exam, but it's important to note that some patients feel the prolapse when they stand, but as soon as they lay down on the examination table, it slides back into place and the doctor goes, I don't see anything here. And yet as soon as you stand up, it can feel like a hard lump of tissue right at the entrance to your vagina. That is a classic finding of somebody with a moderate prolapse. And for severe prolapses can actually start to hang out of your vagina. And when things start falling off out of place, then things are interfering with each other, and you might have a tremendous difficulty emptying your bladder, or you might have more frequency urgency, or you might have an obstructed bowel where you cannot have a bowel movement, or it might be very, very difficult to have a bowel movement. So prolapses are treated based upon the severity of the prolapse. I have a very mild rectocele. So I get a little bulge between the wall between my vagina and rectum. I get a little bulge in there if I have a lot of stool hanging out in my rectum, which I hate. And it's just so mild that my doctor's like, yeah, we don't need to do anything about it. Now, if that pops open and now I've got a hunk of rectum hanging out in my vagina and there's stool sitting there and I cannot move it at all without my finger. If you have to use your finger to have a bowel movement, a finger in your vagina, man, that's a big deal. We're going to have to do something about that. And what the research shows is that surgical repair can dramatically improve symptoms. So stage number 1, if it's mild, we're going to do physical therapy to get those muscles as strong as we can. If the prolapse has gone past the point where the muscle strengthening can help, like you've got really stretched out muscles, the next thing you're going to do is pessary. A pessary is a device that they can insert into your vagina that just holds stuff in place. That's perfectly fine. But once you're at that pessary moment, you really have to understand that it's not going to get better. And the odds are, as you get older, it's probably going to get a little bit worse. And that again brings up the concept of surgical repair. The biggest challenge with surgical repairs is the fact that they often will suggest using a mesh of some type. It's a foreign body that they're going to put in there to kind of tack things up into place. The early old meshes were very, very harmful. So a lot of people are afraid of mesh. If your doctor wants to do it and suggest mesh, you need to get the name of the mesh and you need to research it on your own to make sure that they're not using a mesh where we know we've got a pretty significant history of issues with that. The best case scenario is that they use your own tissue and they don't have to use a mesh. So there are 2 patients that I wanted to share to help us understand just how and why prolapse and your decision on how to treat prolapse can change your life for the better or for the worse. So Shirley had a severe prolapse and severe Hunner's lesions. And because she was unable to urinate, they decided that they needed to go in and try to repair this prolapse. And when they opened her up, they discovered that her uterosacral ligament was broken and that her uterus had twisted out of position. This is a condition called posterior fornix syndrome. So it's a completely accidental discovery. They went in there to correct the prolapse. They found the underlying cause of the prolapse, which was this broken ligament. Well, they fixed everything. They untwisted her uterus. They got everything back in the proper position. And something absolutely remarkable happened. Her Hunner's lesions completely healed. She is considered a complete and total cure. And that helps us understand why, when things fall out of position and get displaced, nerves get stretched, nerves get displaced. And those irritated, inflamed nerves can cause damage to the bladder. And so that's clearly what happened to her. So once they corrected that and got the nerves back into the right spot, her lesions healed completely. She was completely cured of her urinary symptoms. Okay, so that's it's a very, very good success story. The second one is Mary. Mary was diagnosed with a prolapse in her early 70s, and it was a moderate prolapse, so that her doctors at that time said, we really need to repair this surgically, but she didn't want to do that. And boy, did she come to regret that decision. I had talked to her, I don't know, dozens of times over 20 years. And so because she was afraid of the surgery, she opted for the pessary. And the problem happened, of course, is that as she got older, her prolapse got worse and worse and worse and worse until just before she died, her bladder was hanging between her legs and she was a wreck. And literally, one of the very last things she said to me is that she regretted letting anxiety stop her from repairing that prolapse. That if she had done that, she would have had 20 good years instead of 20 bad years tied to the bathroom. So understand that a diagnosis of IC suggests at first that a patient may have a bladder disease. Yet for many of us, bladder therapies simply don't work. And that's when we must ask more questions. Could something have been missed? This cements the importance of a proper physical examination, including a pelvic floor assessment during your diagnostic workup, because as the authors of this latest study say, the coexistence of bothersome pain, bladder, and bowel symptoms is common in women with pelvic organ prolapse. Therefore, it should always be ruled out before classifying somebody or diagnosing somebody with IC. Furthermore, patients should be advised that if physical therapy cannot help, the use of pessaries and or surgical repair are viable options with good success rate at reducing IC symptoms. So hold on a second. So Judy said, what if estradiol cream irritates you more? Is there another solution? Well, yes and no. You can always ask for your estradiol to be made in a preservative-free base. It may be that you're reacting to the base that they've done. But in the end, if you don't give the skin estrogen, it's not going to get better, and it's just going to decline. So finding a way to make that estrogen work is really, really important. Diane said, what is the email you should send the pictures to? It's really easy. Here's my email. You can all have it. Just understand, I get hundreds of email a day, so you got to be the squeaky wheel. Sue said, who's doing the Trigone study? I don't know. I already passed it. Oh, no. I can find it. Hold on. It is, it looks like it's being done in Japan. Tadahira Maruyama Mitsui Sakito Watanabe. Let's see where they are. Department of Urology at Okayama University Graduate School of Medicine in Okayama, Japan. That's a good study. That's really helpful. Here's a link to it. Nicole said, I started vaginal estrogen cream about 2 years ago, and since then I have been UTI free. Recently, my OBGYN found that I have 2 small fibroids in my uterus. Can estrogen flares cause fibroids to grow? I don't know. I know that estrogen can cause your endometrium to get thicker. Are they new? I don't know. Here, hold on a sec. Let me look here real quick. Estrogen does not cause fibroids, but it, along with progesterone, is a key factor in their growth because these hormones stimulate the growth of the uterine lining during each menstrual cycle. And the fibroid tumors are made of this uterine tissue. Okay, now hold on a sec. Here's something else. I mean, they're basically saying hormone imbalance. Oh, I lifted weights, so now my arms are talking to me. Ow. John Hopkins says it's not known what causes fibroids, but studies suggest genetics and prolonged exposure to estrogen may increase your risk of developing fibroids. An estimated 20 to 50% of women of reproductive age currently have fibroids, and up to 77% of women will develop fibroids sometime during their childbearing years. Only about 1/3 of these fibroids are large enough to be detected by a healthcare provider during an exam. In 99% of fibroid cases, the tumors are not cancerous and do not increase the risk for uterine cancer. The people who are at risk for fibroids: family history, obesity, diet high in red meat, or high blood pressure. Interesting. Symptoms: heavy and prolonged periods, bleeding between periods, abdominal discomfort, fullness, pelvic pain, lower back pain, bladder symptoms like frequency, urgency, bowel symptoms, since the growth of most fibroids slows as you approach menopause, your healthcare provider may simply suggest watchful waiting if your symptoms are tolerable. Treatment may be necessary if your fibroids cause significant symptoms. They can do medicinal and surgical approaches. We do have research that shows that when fibroids are removed, urinary symptoms improve, often dramatically. I have done articles on this before, for sure. All right, so hold on a sec. You're taking off a birth control that had estrogen. She's trying her best to lower the estrogen to slow the growth of the fibroids. I've continued estradiol. One fibroid has, one is larger and one is smaller. And your mom had horrible fibroids. Well, there you go. So we got some genetics going on there, my friend. Did your mom have to have a hysterectomy, eventually to have the fibroid? I mean, I've never had a fibroid. I had a bunch of ovarian cysts, but I never had a fibroid. I mean, that watchful waiting is the only thing you can do right now. I mean, aside from, reducing the estrogen and it's never my position or my place to ever get between you and your doctor. My job is to give you a new set of questions and get you back into your doctor's office for a good, meaningful discussion. So, I mean, if I would be talking to your doctor about your mom's history and get their opinion on what the best course of action would be for you, whether it's watchful waiting or etc. Just understand that losing estrogen in general is going to affect tissue, and you're going to start feeling drier and more uncomfortable and potentially more vulnerable. He says you love the estradiol because your UTIs have stopped. Exactly. So I don't think I would walk away from the estradiol at this point in time because it's helping you significantly. On the other hand, I think you have to really watch what's happening with the fibroid and see if it starts to grow. And maybe, just maybe, they might recommend a hysterectomy. I don't know. Deb says, I have a 1 centimeter polyp on my cervix. They want to dilate the cervix to pluck it out, as they say. Question, can the Ovestin cause that? I've been using it. They say it's painful without anesthesia, and I want to do it with local. What should I do? And yes, mine is new. So what they're going to do is there a specific a hysteroscopy? A hysteroscopy is where they numb the cervix and then open the cervix, usually to take a sample of your uterine lining. In this case, they're going to open the cervix to get a closer look at that polyp. It's interesting. There was somebody on YouTube, like in the last couple of days, they were really angry that their health insurance company denied anesthesia for an event just like this. That obviously cutting tissue when you're awake is not the funnest thing in the world. And so she did this rant about her insurance company not providing anesthesia. What was so interesting was looking at the comments, because a lot of people, who've had it done said, said, no, we don't normally do general anesthesia for this. And they didn't do that for me. I had that done. That basically, it's like the biggest needle you've ever seen, so don't even look at it. You're in stirrups, they open up your vagina, and then they use this needle to numb the cervix, and then they gently open the cervix, and then they take a quick grabbing motion and pull some tissue off. And my sister had this done, and she called me from her car sobbing, and she said, don't ever let anybody do this unless I'm with you. And then years later, I had to have it done, and she came with me in the room, and she held my hand, and when they were doing it, she squeezed my hand really hard to get me to focus on that. And it really was just a moment in time. Now, granted, I had a really good OBGYN. It was really good at numbing, but it was, 20 seconds of sharp pain, and then it was over. And so now that I've had it done, I wouldn't be scared of it to do it again if I had a uterus. Unfortunately, my biopsy came back as precancer, and so I had a hysterectomy, and they took my cervix. So in my opinion, I think I don't like guessing. I like facts. Your life is at stake here. I would not let fear stop me from getting that polyp checked. And if that comes back negative, you're good to go. That's fantastic. But if it happens to come back as atypical cells, as mine did, not active cancer, it was like the cells that become cancer, at least you know and you can do something. So I would be all in there, and like I would make that appointment as quickly as you can, like just get in there, get it done, and just know. Because the thing too is that, well, and mine was the same, Deb. My uterine lining. See, I started spotting, and it looked like pink lemonade. So I had this pale pink spotting on my mini pad because I wear mini pads often, not all the time, but often. And so I noticed this pale pink thing, and it was very persistent. And I thought, well, that's a little weird. And I reached out to my doctor and I said, hey, I got this weird pale pink discharge. And he was like, yeah, we should check. Why don't you come on in and make a check? But then he said, yeah, but you're using oral estrogen. And so it could just be that. So it's probably that. So let's not worry about it. I mean, I don't think he said it exactly like that, because he said, you should come in and we should get a check. I didn't want to do that because I could remember my sister having that reaction. Well, that started in August. Well, the week before Christmas, I was passing blood clots. And he got me right in. What did they do first? No, I think, okay. So he got me right in and they did a sonogram and they measured my endometrium. Normal is like 2. Mine was like 4. And he said, well, you're on estrogen. You're building up your uterine lining. Let's see if we can force a period. So he put me on progesterone for 3 months. Yeah. And you know that feeling you get right before your period's going to start where you're just like, you're going to explode. I mean, that's just awful that hours before your period starts. That's where I was for 3 months with this progesterone. I go back in, never started a period. I go back in, they remeasured my endometrium and it was 8. It had grown. And he went, okay, that's not good. I have to look in your uterus. And so he said, we need to do a hysteroscopy. And that's when I called my sis, who's my saving grace, and said, okay, we got to do this. She goes, okay, I'm going to be there right with you. And what did I do? I think I took a little pain med before. And we were in and out in 15 minutes. It wasn't that bad. And I just remember that I bled for I had to wear a menstrual pad, but we went to a nursery afterwards. So, I mean, it's just like menstrual cramps and cramping. Those test results came back as complex endometrial hyperplasia with atypia. And they thought it was, like you, a polyp. And so when he saw that, he goes, we need to do a D&C. We need to look inside your uterus now. I need to really look and see what's going on. And obviously that's done in the OR. And what they found was a very large polyp that looked like a white tongue. Creepy as hell. Probably caused by the oral estrogen. And so they pulled that out and I saw pictures and they biopsied that. And that's where they were like, these are the cells that become cancer and we cannot guarantee that you do not have cancer right now in your uterus. So the next stage of treatment is a hysterectomy. And I don't listen, once somebody says something like that, it's like, all right, let's do it right now. I don't want to wait. Let's do it. And I had a hysterectomy 2 weeks later. No regrets, no regrets. I will tell you, Deb, that was the first time I've ever asked our medical advisors for personal advice, because I was really scared that the hysterectomy would start all my pain up again. And so I sent them all an email and said, okay, this is what we found. The doctor is recommending robotic laparotomy or Da Vinci laparotomy for the hysterectomy. I'm terrified that this is going to make my IC worse. Can you please, what advice would you give me, or what would you suggest? And every single one of them said, honey, your life is at stake. You've got to do it. But more importantly, he said, rarely do we see patients get worse. Their IC get worse after having this done. And I mean, every single one of them said that. So I was just like, okay, let's do it. Let's do it. Now, with luck, it's fine. With luck, it's just a thing. It's just a goober. But if it's not, man, let's get that sucker early. Let's get rid of it early. You can do this, girl. You're tough. You're strong. So, yeah, you're having the aneurysm surgery on the 10th first. Woo, you are busy. You are going to have a stressful holiday season. And Deb, I just want you to put yourself first. You don't have to make this special for anybody else right now. They need to help you. You don't need to help anybody. So, man, it's very, very important that you respect how you're feeling. I would be getting as much support as you can. Talk to your girlfriends. You can call me just to try to give yourself a way of releasing some of the stress, finding some hope, finding some comfort here. I've been through it. I made it. I'm here today. I made it. And most importantly, understand that the human body is trying to heal you right now. Healing never turns off, ever. And so let's get through the surgery. You're going to have a very calm, peaceful, gentle holiday. Pace yourself. Go slow. This is time where you're going to eat your favorite foods. Just chill. Because this is about you right now. You get to use the holidays this year to sit in front of a fire, reading your favorite books, drinking your hot chocolate, or drinking whatever gives you comfort to get you through the surgery. And come January, the hardest surgery is over. Good job. Well done. You did it. Pace your healing. Go slow. Nothing's going to happen overnight. Calm, gentle, soothing, comforting. Ask for help if you need it. Ask people to bring you cookies. Ask people to bring you turkey. Give them the opportunity to learn how to care for somebody else. Don't try to do, that's just important. Deb says, I know, let's see. Thanks, Jill. I'm just wait. Okay. I know, Jill, going through so much, and now with the essential tremors with all this. My doctor said to me, if I was you, I'd give up with all you have going on. I couldn't believe it. Jill. Then he said, no, I'd be having a meltdown in my doctor's office. See, here's the thing, Deb. You and I, we don't have public meltdowns. We have private meltdowns. People don't even know we're melting down. On the inside, we're a puddle. But to everybody else, we just look strong. And I don't know how to fix that. I don't know if that needs to be fixed. All I can tell you is that I believe that God wouldn't give us stuff if we weren't, I don't even know how to say this right. I believe in faith. I believe in God. I believe that when things like this happen, there's something that we're supposed to do with this, potentially. Maybe there's somebody else that we need to help who's gone through this. That's how I approach my life. Deb said, the only problem is I have another aneurysm they want to watch that needs, yeah. And Deb says, true. I sobbed when I found out, and I just sobbed. Yeah, girl, I cried every day for, oh my God, months. And it was just random, just out of the blue. I mean, I'd be driving, I'd start crying, or usually driving home from family events, I would just sob. And you have to let it out. There's nothing wrong with crying. You have to release the emotions. If you leave them in here, you just become this tornado of pain and stress and worry and anxiety, and that's not going to get you where you need to be. This is why journaling is so good. If you can just, I mean, when I'm at my worst, I journal. And so what that means is that before I go to bed at night, I write 3 pages longhand in a journal, and I write down everything that's bothering me. It is a purge. It's just like, I just want to be done. So I know that if I've committed it in writing, I have physically let it go so that I can sleep easier. And then in the morning when I wake up, same thing, 3 pages longhand. Now, it's not a big journal. It's a little journal. I mean, it takes 5 minutes. And my goal in doing it in the morning before I even get out of bed is I want to release all the worries and stress first thing so that I don't dwell on them all day. And that just reminds me I need to journal more. Because life is really complex right now for many, many different reasons for all of us. And the point is to let them go. There's a wonderful, when I was in grad school, we learned a bunch of techniques that we could use with children. And one of the techniques is called the pink bubble technique. Well, there's 2 techniques we use with children that I use on myself. The first one is when you go to bed, you visualize a bubble around you. And this is a strong bubble. Like nothing gets in this bubble. You are protected inside this bubble. And if a threat comes, they cannot get through. And I mean an emotional threat, a worry, anything like that, nightmare, anything. Man, you have got this strong bubble that is protecting your heart and your soul. And it is wrapped around your bed or wrapped around your bedroom. And only you get to determine who gets through this bubble. Nobody else. So all your troubles bounce off of the bubble. And that's a great technique to use with kids who have nightmares. The other one is called the pink balloon technique. And basically what you do, is visualize that you're holding the string of a balloon, a helium balloon. And up this string, you direct all of your worries, all of your stress. So you close your eyes, you're holding your string, and you visualize your pain coming up from your bladder, coming up your chest, going to your shoulder, going down your arm, entering the string, going up the string. And the balloon starts to get bigger, and you're filling it with anything and everything that's upsetting you. Whether it's pain, whether it's stress, whether it's worry, just close your eyes, just let it go. And let's just empty out our soul, empty out our mind, our stress. We're releasing our soul. We're tracking it from our shoulder, down our arm, to our fingers, up the string, and you see it getting bigger until eventually you got a big old balloon of stress and worry right there. There it is. You've released it. It's all right there. And then you open your fingers and you let it fly away. I had a friend of mine, Linda, who was in my support group. I'll say her name, Linda Roper. I loved her dearly. She had very, very severe IC. She had severe pain. She was in pain care. This was years ago. And she died many, many years ago. She was somebody who had a terrible IC flare, goes to the emergency room. They told her it was her appendix, and they removed her appendix mistakenly. I mean, the care that we used to get 30 years ago was horrific. So anyway, she had pneumonia and was in the ICU on a ventilator. So she was in a coma on a vent, and her family called me, and the vow that I made to everybody in my support group is, if you're in the hospital, I will be there every single day. And so if you tell me, if you don't want me to come, that's fine. But if you want me to come, I will be there. I love being a support group leader. And so I went and sat with her in the ICU every day for a week. And we did the pink balloon. We did it every single day. Now, of course, she wasn't reacting to me at all. She was in a coma, on a loud machine. But I just kept talking to her and doing it. And then she woke up. She responded, and they took the vent out. And I went the next day. She'd woken up and run in, give her a hug. Oh my God, you're here. And she looks at me and goes, "What's up with the balloon?" Sorry about that, Sherry. While she was in the coma, she heard me. And she remembered everything. She remembered filling the balloon with her pain. She remembered letting it go. And that was a really, really powerful moment, to think that whole time she was there, she could hear me. So, these things work. So just let them go. Listen, we can't change the past. It's over. It's done. What do they say? If you're anxious, you're lost in the past. If you're sad, you're worried about the future. You have to focus on today. What can I do right now that will give me some comfort? And I used to end these meetings with homework, for 15 minutes a day, you need to read about IC and build your knowledge level up. Watch one of our Living with IC videos or masterclass videos. For 15 minutes a day, you need to work on relaxing your muscles. For 15 minutes a day, do something that will calm your bladder, fix a nice meal. And then I always ended it with, for an hour a day, I want you to laugh, because we just have to, try to release the trauma of it all. Listen, I understand nobody wanted this. I didn't want this. It happened. It could be so much worse when we put it into context. We're not scarred. We haven't been burned. We have our limbs. We have our brain. Sometimes we have to give ourselves a bit of a reality check. But it's hard. But we can do it. You can do it. You just got to be willing to commit, got to learn as much as you can. You got to be willing to be proactive, talk with your doctors, ask a lot of questions, try new things, try not to cling to old things that haven't worked in the past. Listen, if Elmaron didn't help you and you're still flaring, why are you still on it? If bladder installations didn't help you, why are you still doing them? That's one thing our national guidelines say, is we don't want you to spend any more time doing and wasting money doing things that don't work. If you're not responding to that therapy, stop what you're doing, take a step back, and revisit that diagnosis. Could we have missed something like, hello, Lyme disease? Be the squeaky wheel, be persistent, and be brave. It's hard to advocate for yourself when you feel like shit. Excuse me for swearing, but that's the truth. You want somebody to come and rescue you. I've always wanted somebody to come rescue me. And if there's one theme in my life, it's, Jill, you got to do it on your own. Nobody can stop you from drinking Gatorade. You have to stop drinking Gatorade. Nobody can stop you from drinking coffee. You know it's irritating your bladder. You're still doing it anyway. You can do that. Be bold, and mighty forces shall come to thy aid. I'll tell you, when I had, I mean, I should just write a book about my life. It's been so weird. I had to dramatically change my diet after losing my gallbladder. Because when you lose your gallbladder, you cannot eat saturated fat. If you eat saturated fat, you have something called bile diarrhea. It is diarrhea so sudden and so severe, you cannot even get to the bathroom in time. Happened to me twice. I have no shame. I will talk about it. Thankfully, I was home. It's like all of a sudden, damn, where'd that come from? And you go through that a couple of times after eating the wrong thing, it's like really easy to not eat that thing again, which is why I have not had butter in a year and a half. And, there usually comes a point in time when we all say, I don't want to ever go through that again. It's like when you're young and drinking and finally you're throwing up in front of a toilet. Most people go, all right, I'm done with this. I don't ever want to go through this again. It's easy to not drink so much. It's easy. And with bladder pain, it's easy to stop coffee if you can directly see that coffee is hurting you, or alcohol. And if, God forbid, you've lost your gallbladder, it's really easy to stop the saturated fat because it's a horrific experience. But we learn from it. So anyway, all right, my friends, listen, I'm here as long as you have questions. We have been going now for, what time is it? 3 hours. We are at the 3-hour mark in 2 minutes. So let me do this. I was going to drive out to the ocean after the meeting, but it turns out it's a very foggy and it would be very cold. So I am not going to do that. So instead, I think what I'm going to do is work on some Christmas decorations. So let me do a last call for questions. And if you find these meetings helpful, please come on over to the IC Network. It would be great if you bought some stuff in the IC Network shop, or you became a member to get our magazine, because that's what keeps me doing these meetings. Okay, if we have to have money to pay for the internet, and we get that from our shop. Joan, thank you for the 99 stars. I really appreciate that. That's very helpful. Stars over time help. All right, so last call for questions. Last call for questions. What am I going to eat today? I'm going to have a chicken sandwich, which is my go-to. Hi, Roxanne. Oh, thank you, hun. Roxanne said she's new to the channel. You learned so much. I'm so glad, hun. I always like to tell people, listen, I mean, when I started the IC Network 32 years ago, I was not welcomed. I mean, I've got a lot of training, a lot of degrees, health degrees and psychology degrees. And I think I was probably fairly intimidating back then, because I knew I knew how to run a support group and do it well. it was not easy. Because people didn't understand the internet. People didn't understand how we could use the internet for good. People did, and I spent a year and created data showing that people use the internet in the middle of the night when they're having flares. And so I knew it would work. I knew it would work, but the powers that be didn't believe me, and I got lectures on knowing my place, and that is starting a website on IC, doing support online, stupid ideas, and I was pretty much threatened and intimidated for years by certain people who did not want me to do what I do. Well, I have outlasted them all. I am still here 32 years later, and I am going to be here for another 5 or 10 years, God willing, continuing to do this work, because there are patients suffering right now. And, you know, they need hope, they need comfort, they need information. So the point that I was going to make, I kind of lost my train of thought there, is one of the ways they used to attack me the first 10 years of the IC network is they would say, don't trust Jill, she's profiting off a patient. And my answer was, where? It's free. Like this meeting is free, right? Our website's free. I didn't have a store. I didn't have members. I didn't have a magazine or anything. It's completely free. If I had been charging, we were working with 200,000 patients a month. I would have cleared $1 million a month. And I kind of, you know, I was like, oh God, I could use that now for my retirement, but it's free. It's always been free. It always will be free. As long as I can do it, it's going to be free. Because my market are not rich patients. My market is poor patients. I want patients who are struggling. Those are the ones that I care about, because I know they don't have resources, and we want to try to help them. So anyway, there are people online right now who will say, pay me $500 a month and I will teach you all you need to know about IC. And my response to that is, you don't have to pay anybody $500 a month. Go to our website. It's rated #1 by Harvard Medical School and the University of London. You know, it's taught in medical schools. We have referrals every day from newly diagnosed patients. It's free. So you don't have to pay anybody to learn about IC. And so for anybody out there who is trying to entice you to pay them a couple $1,000s to learn, save your money. That money needs to go into physical therapy. That money needs to go into treatment. That money does not need to go into somebody's pocket. You can learn as much as you need to from our website. Okay? Deb says, thank you for your time and for caring. I just hope this polyp isn't causing pain. Girl, you call me. You call me. Let me know. Let me know when you get the results, and you're not alone in this, okay? Larissa said, thank you, Jill. Deb says, but I've had the pelvic pain for a long time. I know. Roxanne says, does pre-leaf help? I may have spelled it wrong. Roxanne, pre-leaf reduces acid. It doesn't act on your body. It's not a bladder treatment. What it does is it reduces the acid in the food that you might be eating, so that your bladder is not as irritated from it. But the big thing you've got to understand, my dear, is that not every IC patient is the same. There's tremendous diversity in the IC patient population. So 30 years ago, when I was diagnosed, we all assumed we all had bladder disease. Today, we don't do that anymore. Today, we now recognize that most IC patients have a neuromuscular origin causing their symptoms. And so our goal now is, rather than assume you have a bladder disease, we want to try to identify the underlying cause so that we can treat the underlying cause in the first place. So you know what I'm going to do here is I'm going to play episode 4 in our masterclass on Facebook. I'm going to let YouTube go. YouTube's done. There's nobody on YouTube right now.